All right, it looks like we're good to go, right, Alex? Good morning, everyone. Thank you for joining the Insurance and Real Estate Committee's forum on barriers for individual providers. This has been a journey with the Insurance and Real Estate over the summer, fall, and into this session, really diving into costs that are going into healthcare. I want to thank the committee members for organizing this. And thank you to all the panel members for agreeing to come on. We really look forward to hearing your perspectives. I want to open this up to welcome remarks. I see Senator Wong. Pass it over to you, ranking member on the Senate side.
Thank you, Madam Chair, and I'll be very quick. I want to thank you for doing this and for the colleagues on the committee who kind of worked to make this happen. I'm very eager to hear about the independent providers and my kudos to them on a sidebar to thank them for being on the front line of this COVID pandemic and caring for the people and ensuring people's safety and health. So I'm appreciative of this. I want to thank you for spearheading this as well. Thank you, Madam Chair.
Thank you, Senator. I see our ranking member Pavlak D'Amato is still joining, so I will ask my Vice Chair Robin Comey to say some welcoming remarks.
Good morning, everybody. Thank you so much for being here, especially to our guests. Thank you to our staff for making this possible. We couldn't do it without you, and also to Chairwoman Wood for putting all these pieces together. And I know it's not an easy task to do, but I appreciate your dedication to bringing all of these players together to make sure that we can serve the folks of Connecticut as well as we can possibly do, not only during a pandemic, but through our committee work and the years to come. So thank you to our guests. I look forward to hearing everything that you've got to talk with us about. Thank you.
And ranking member on the House side, Rep. Kara Pavlak D'Amato. Any welcoming remarks?
Just good morning and thank you for having this. I'm very excited to get started. Hopefully I won't have this voice when we go to the Capitol, but again, thank you everybody and can't wait to get started.
Great. And with that, we're going to start with our first speaker, Jeff Hogan. Jeff is the president of Upside Health Advisors, and that will be followed by Lisa Trumbull, CEO of Southern New England Health. Jeff, go ahead.
Thank you. Chairman, representatives, thanks for giving me the opportunity to speak with you today related to trends in healthcare, states that are doing innovative and proactive things to address healthcare costs and quality, and generally to talk about the providers and health systems and how they're changing, not just in Connecticut, but around the country as well. Thank you for your public service. I served in public service for 15 years in Farmington on the town council. I finished as the chair of the council in 2014, and I know how hard all of you work. So thank you so much for that. I've worked in healthcare nationally for 35 years, mostly focused on the purchasers of healthcare, namely employers, and the supply chain of healthcare, namely providers, health systems, and what we'll call point solutions. And we'll talk more about that in a couple of minutes. Healthcare consumes nearly 18% of our gross domestic product, and healthcare trend, which is inflation apportioned to healthcare, regularly far exceeds cost of living increases. Our healthcare system has fragmented outcomes, is complex and inefficient. Since COVID hit, things in healthcare have changed dramatically. In fact, COVID has inspired a huge influx of investment and capital into the healthcare ecosystem. Further, expectations, and this is a big deal, expectations associated with healthcare delivery and financing have changed dramatically. And this newly born healthcare consumer is demanding more and better from our healthcare system. The demand is driving the move for value-based healthcare, and I'll describe what value-based healthcare is in my remarks as well. Presently, I have the honor to work as a national healthcare consultant and advisor for some of the largest healthcare purchasers and purchasing coalitions in the country, including the state of New Jersey Employee Health Plan, with over 800,000 active and retired employees. I also work directly with some of the largest tech-enabled advanced primary care organizations and point solutions who are actively disrupting legacy healthcare. So just to describe what is tech-enabled advanced primary care, about a year and a half ago, the National Primary Care Collaborative, the National Alliance of Healthcare Purchasers, and the Pacific Business Group on Health came out with what this paradigm looks like, the tech-enabled advanced primary care organization. And basically, the paradigm suggests that the organization is capable of taking and managing risk on patients and populations. Two, that they've done what we call care transformation, meaning that they apportion an integrated practice unit, which includes the physician, behavioral resources, PharmD resources, and a health coach to patients to steer them through their care journeys. And third, that there's a patient engagement aspect or a consumer aspect to gauging the consumer experience for the employee. Care transformation also assumes that the patient can be seen in person and virtually, interoperably, meaning that the providers have access to the patient's electronic medical or health record and can coordinate care through their many providers, especially for complex care and things of this nature. So it's a big deal. That's a big expectation. The largest employers, including state governments, Fortune 500 companies, are utilizing these accountable solutions. They're using APCs to direct care to the lowest cost and highest quality facilities and providers in a predictable way. And this is really important. In Connecticut, specifically, I serve as a member of the governance board for the Moving to Value Alliance. It's a big tent group, which has been around for 6 years, representing payers, providers, purchasers, health systems, employers, and consultants committed to moving healthcare to a value-based rubric. Dr. Steven Schutzer will follow me later in this program, and Steve founded the program. The state of Connecticut, Tom Woodruff, Vicki Veltri, Ted Doolittle have been engaged in contributing members of the group from the start and thought leaders in this space. The group is committed to a system focused on superior access to care, lower healthcare costs, and predictable high-quality outcomes for members. 16 years ago, Harvard professor Michael Porter and Elizabeth Teesberg wrote a seminal book which started the value-based healthcare movement called Redefining Healthcare. They predicted that our opaque, fragmented, complex, and inefficient healthcare system would be disrupted by disruptors and innovators. I'm here today to tell you that their prediction has come true and that states and purchasers across the country are implementing data-driven healthcare policies focused on payment reform and care transformation. You'll hear a lot about that today from those who follow me. This is the heart of the matter. You now have the data and the resources to demand better from the system and to use your leadership to demand predictable prices and high quality. Those who follow me will talk about how they are transforming their own legacy provider groups and using national organizations to provide superior, coordinated 24/7 access to care that is clinically integrated to other providers and health systems. This is critical. The bottom line is that there are provider groups, health systems, and even payers who are adopting and adapting to the new demands of Connecticut consumers and purchasers by delivering advanced primary care that steers into targeted price and warranted episodes of care for the highest volume and highest cost procedures. The RAND Hospital Transparency Report can show each of you the huge variation in cost and quality that exists between health systems and service lines here in Connecticut. Value-based healthcare solutions show a clear pathway to lower costs and superior quality outcomes. Please note that many states have adopted these strategies and actually demand them as part of their public policy initiatives and via the technological infrastructure they finance to manage these strategies. States like Massachusetts, the Mass Health Policy Commission, Maine, Rhode Island, New Jersey, Colorado, Washington State, and others are focusing on the supply side of healthcare to demand care transformation, payment reform, and high quality. Taxpayers are the clear beneficiaries of these initiatives. I look forward to the rest of the program today, and thank you for the opportunity.
Jeff, thank you so much for that introduction. I'm sure, like myself, our members have a ton of questions, but we'll go over to Lisa Trumbull from Southern New England Health and followed by Sue Halpin. And then we will open up section 1 for questions to our members. Thank you. Lisa, thank you for joining us today.
Okay, thank you very much, Rep. Woods, for inviting me. And I'm clicking on sharing the screen, but it's saying the host disabled participant sharing.
Alex, are you on to assist?
Yes, let me make sure that this is working.
It looks like I got it now. Good. Okay, are you able to see my screen and see my presentation? Just to check to make
Yes.
sure everything's working well. All
Yep,
right.
we can see it.
And you have a full screen. Okay, so thank you, Representative Woods and committee members for inviting me to talk to you today. My name is Lisa Trumbull. I'm the president and CEO of Southern New England Healthcare Organization. I have over 30 years experience in healthcare, covering large group practices, integrated delivery systems, and you can see my experience here and my key skills throughout my career. Most of my career has been based in Massachusetts, so I'm new to Connecticut. I have a deep experience in Massachusetts, working with the state of Massachusetts and the Medicaid program to reform how Medicaid was delivered in the state of Massachusetts. So I'm looking forward to this discussion. So who is Southern New England Healthcare Organization? Southern New England Healthcare Organization is a clinically integrated network. And what that means is a clinically integrated network is a legal form or a legal way to construct and organize hospitals, physicians, and other healthcare providers to join together for the purposes of improving the care and the outcomes of care for the patients that we contract for. So Southern New England Healthcare Organization is a clinically integrated network. Our network is comprised of over 1,600 providers throughout the state of Connecticut and through Massachusetts. We're in both states, Massachusetts and Connecticut. We operate and cover about 200,000 covered lives today. We are affiliated with the 6 Trinity Health of New England hospitals. And over the last 4 years, we've managed $6.1 billion in total cost of care. And that's inclusive of everything that is every piece of care that's delivered to a patient. Over the last 4 years, we've saved our payer partners, CMS and Medicaid, $123 million. And last year in 2020, through the Medicare Shared Savings Program, we scored in the 96th percentile for the quality of the care that we provide to our patients. This is just a sample to give you. We contract currently with all the major payers in the Connecticut market and in the Massachusetts market. We are currently, as Jeff spoke about, value-based payment structures and numerous value-based payment structures, alternative payment models with downside risk, particularly with Medicare and the MSSP program in Massachusetts Medicaid, as well as Medicare Advantage programs, commercial, and the Medicare bundles programs. We have, in addition to that, rolled out over 15 procedure and chronic care bundles that are focused on setting the value of the care that's delivered for each of these bundles, and providing an opportunity to fix the cost and deliver on the quality for these conditions. We're also we're selected as 14 networks of distinction for the state of Connecticut for the employee health plan. And I'll cover briefly in my comments today our direct to employer strategies, which is new to the market, in a way to go directly to employers between a provider and the employers to arrange for healthcare services for their employees. And then lastly, and we're numerous tiered employee plans because of our cost and our quality profile. So, when we talk about value in healthcare, what do we mean by value? What's generally known in the industry is value is delivered when we're looking at the quality of the service, the quality and the service that's received by the patients over the cost. So are they receiving the right quality and the right service for the right price point? And is all of that transparent in this process? When we look at value-based care, we're looking at, are we providing the right care at the right time in the right setting with the right provider all the time? There's huge variation in healthcare today, and that variation drives up cost. That variation occurs when services are overused, misused, underused, or adverse events occur. And anytime something like this happens, the employer or the patient pays more because the cost for the service is more because we're not delivering on a standard of care. So what do we need to be successful in a value-based care environment? We need, of course, high quality providers, hospitals, and a full continuum of care that go beyond just hospitals and physicians. We need a level of clinical integration. Clinical integration is key to delivering improved health outcomes in terms of quality and cost. Without it, it's fragmentation, and that just increases cost. You need a strong clinical leadership and infrastructure that can evaluate and reduce the variation that occurs on a daily basis with care that's delivered to patients. And we need aligned clinical and financial models. And we don't have aligned clinical and financial models in the state of Connecticut. We don't have financial models in the state of Connecticut that actually advance this, this paradigm. And then lastly, we need data in two ways. We need data that gives us a 360-degree view of the patient that we're caring for and the needs of the patient. And we need data to improve our performance. When we look at value-based care, how does this start? It starts with the ability to attribute a patient to a primary care provider. It's necessary to have a primary care provider and a patient relationship in order to achieve any value proposition. If the patient doesn't understand that they've got a primary care provider that's going to help them, and a primary care provider doesn't believe that they have a patient attributed to them, then no one's paying attention to the care that that patient's receiving. In a value-based model, an attributed patient to a primary care does two things. It makes the provider accountable for the care and responsible for the whole person. And the whole person care covers everything from specialty providers to hospital care, post-acute care, home care, pharmaceuticals, whatever may occur with that patient. It aggregates the results of that with that single primary care provider. And that's what we're in the business of doing at Southern New England Healthcare Organization. And we're doing this in a clinically integrated fashion. As I said, we're managing over 4 years about $6.1 billion in care. And you see the numbers that we saved. But just to call out what we did for CMS in 2020, we saved CMS $22.4 million for the Medicare patients that we were caring for in that program. And we earned as an organization for all of our programs over $28 million because we're taking risk. If we do better, we are paid for doing better. If we do worse, we pay back to the carriers if we do worse. And as I said, in the Medicare Shared Savings Program, we were #1 in the state of Connecticut in 2020 and #3 in the state of Massachusetts. And so you may be asking yourself, well, what does this really mean to be clinically integrated and driving value? If you look at the graphic below, by and large, when we compare ourselves to others in the market, on average, our cost for certain conditions is 22% lower than others. So if we look at a major joint replacement, that 22% difference is significant. And it's significant both to the employer and to the patient and to the state and municipalities that are contracting for healthcare services. And if we're not paying attention to the integration and the components of variation, then you all will pay more for the healthcare services that you're receiving. And what are we doing to innovate in this market? As Jeff commented, there are numerous innovations and disruptions that are occurring in our marketplace today, and Sohn's embracing those. We're looking for any way we can to disrupt the traditional healthcare environment. That includes partnering with digital solutions, new information sources, and other market disruptors like the Dispatch Healths and the Vera Healths, of the world, and incorporating them into our sphere of care, which you can see on the right-hand side here. The traditional healthcare system of just needing a hospital and just needing your provider, doesn't exist anymore. In order to manage healthcare, all these other components need to be considered and integrated. Otherwise, everybody's just providing fragmented care to patients in the marketplace. In addition, we've expanded for our network, our continuum partnerships to incorporate skilled nursing facilities, virtual behavioral health services. There's a complete lack of behavioral health and substance use services in Connecticut, and it's desperately needed in order to impact the cost of care. If we can't figure out behavioral health and substance use, we are not going to correct medical use. So it's important that we have an answer for that, as well as incorporating preferred home health agencies, mobile integrated health, and relationships with community-based organizations, because healthcare is local. They know more about how to connect patients within the community than we do as providers. And those relationships are incredibly important to our ability to succeed. And then lastly, I said I would give you an example of our direct to employer strategy. We currently have a relationship with Centivo. Centivo is a third-party administrator that contracts with small employers, generally under 500 employees. And we help them design a network and are part of a network that contracted with Stu Leonard's recently over the last 2 years. And within the first year of the contract with Stu Leonard's, we were able to generate 50% of their employees selected this narrow network product. There was a 35% decrease in cost, which is inclusive of claims, administrative, and stop loss, and an 81% reduction in member out-of-pocket costs. That's real savings to employers and to employees. And this doesn't even touch the quality improvements that they've experienced and the reduction in ED and inpatient admissions that were experienced to generate these reductions in cost of care. So what we're talking about can be done. It needs some legislative juice maybe to get others interested in doing this in the state of Connecticut, because it's being done elsewhere. Thank you. I appreciate your time, and will forward my presentation to you all.
Lisa, thank you so much for that presentation. I feel like we could have you present for another hour and still be sitting on the edge of our seat. So I really appreciate you summarizing so quickly. Last speaker in section 1 is Sue Halpin, and then we will open it up for questions to our committee. Sue, are you ready?
Good morning. Thank you for having me. Quick hello to the chairs and ranking members of the committee, and also to all the members. It's a pleasure to be before you. I do not have slides, so great. So I'm just going to be, talking generally and providing a little bit of a backdrop to the previous speakers. You just heard so much about value-based payment arrangements and about the opportunities that it presents. As most of you probably know, I act as the executive director of the Connecticut Association of Health Plans. Our members include Aetna, Anthem, Cigna, Connecticut, Harvard Pilgrim, and United. I would like to associate myself with all of the remarks, that were already mentioned, because we too are very much embracing value-based payment. And much of what you heard today has been the result of collaboration between the parties that you're hearing from today. And if I leave you with one sentiment as we end this forum, it is collaboration and voluntary nature of those conversations going forward. And I think what illustrates that best is really an understanding of the insurance market in Connecticut. You heard a lot about what's happening in markets across the state, across the country, to our neighboring state in the north, et cetera. And there are a lot of things also happening here in Connecticut. You'll hear about those from Vicki Veltri later on in your forum. They're not headline making, they're not resonating, in the public domain, but they're really important discussions happening both at the state level through the Office of Health Strategies and also through the Moving to Value Alliance that you've already heard about today. So there are things that are happening, but all of this, has to be looked at in Connecticut. You've seen one state. Connecticut is very unique in the way that our coverage sectors work. Just to start, you've got about 20% of the population that is in Medicare, right? So the governance of the Medicare products are all done at the federal level. And you must adhere to the rules and regulations coming out from the feds on this. You've got about 20% of your market here in Connecticut that's Medicaid. And that's about 900,000 members or more that are out of the, I don't want to stop, but I know Representative Meskers has his hand up. So I just want to make sure that I'm being cognizant of that.
No, you can keep going, and then we'll open it up to questions after. He just can't wait to ask.
He wants to be first. No problem. So, you've got about 900,000 rounded up to 1 million out of 3.5 million in Connecticut that are on your Medicaid plan. That leaves about little less than 50% in commercial, 47.5. And commercial, it's really, really, really important to understand that about 75% of that 1.7 million, I'm using rough numbers here, but so about 1.275 million people are in self-insured products. And a lot of what you heard today about the value-based arrangements and all of the innovative things that are coming out of that are happening in that self-insured market and have been happening for some time. And in fact, a lot of those efforts and initiatives are now being modeled by other programs in the state, but they are the laboratory, if you will, for a lot of this value-based payment arrangements that you're hearing about. Everybody says, well, who's self-insured, right? And I'm sure Jeff and Lisa can articulate that probably better than I can be. But one of the biggest self-insured policies issued in the state of Connecticut is the state employee plan and the associated partnership plan. So anything that the legislature does or passes must be voluntarily accepted by those folks in the self-insured market. The legislature doesn't have the authority to force those conversations or to force that deliberation or that acceptance of those new policies. And so that's why I go back again and again to collaboration. And again, it's not headline making, but it's where the action is. So when you talk about things that the legislature, would like to enact, you're talking about the fully insured market, which is about, let's just say, roughly 425,000 out of the 3.5 million people in Connecticut. And that fully insured market, they're there for a reason, right? When you're self-insured, the employer is paying their own claims. They've hired, a third party.
Thank you, Sue. That's our time, and if you could wrap up, and then we'll move on to questions.
I will wrap up. So just bringing this conversation full circle, and understanding that collaboration and that there are things that are coming to fruition now that have been passed by the legislature in previous sessions, right? All of the work around the HIE, the Health Insurance Exchange, the Central Repository for Medical Records. There's an all-payer claims database that is being used for public health analysis and initiatives to determine where the greatest needs are. You've got things happening in the private sector under the Moving to Value Alliance. You've got things happening in OHS. So I guess my parting words are collaboration and recognize the work that is already ongoing that folks are doing in this market. And with that, I will be quiet. Thank you very much for the opportunity.
Thank you, Susan. We appreciate the overview of the numbers, really about the data of where the plans are and how many people are in them in the state, because I think it's important for us to hear that information as much as we can. I want to ask a few questions, and I'll turn it over to Representative Meskers. First, Jeff, can you talk about how government states in other parts of the country are saving their taxpayers' money with this care transformation? I think that's really what we're interested in here in Connecticut, is the role this committee and other committees can play in helping move towards saying to our taxpayers, we're good stewards of your money, and we're also going to provide you the best quality health care that we can.
It's a great question, and so simply stated, other states realize that their large employee health plans, and in other states, for example, with New Jersey, not only is it the state employee health plan, but municipalities are apportioned much like the partnership program is as well. So, for example, in New Jersey, that plan spends $5.7 billion a year. Think about that. It's just a huge number. So in most every state that is taking a proactive stand, what they're doing in Connecticut has already done this, and Tom Woodruff has been very active in doing this, is looking at those things, those big chunks, those episodes of care that are the highest volume and the highest cost. And what are those sorts of things? Arthroplasty, knee replacements, hip replacements, babies, cabbages. I could go on and I would give you a list of these things. These are the things that are most common in their health plans and comprise the largest chunk of costs. Also, things like specialty drugs. Specialty drugs are consumed by about 2% of your population, but can represent 18, 20, 22, 24% of total cost of care. And about 50% of specialty drugs are on the PBM side of the plan, and about 50% are on the med pharmacy side. So they look very specifically at those things that are the biggest volume of procedures, and do very simple analysis on what we call, it's a Prometheus analysis or episode of care. What do these things cost? What does it cost to replace a knee or a hip? And what is the variation that exists across our systems? So I was very lucky a couple of years ago to work with Vicki Veltri on a project that we were able to get Connecticut's all payers claims database information into the RAND Hospital Transparency Report for the first time, and thereby show Connecticut the huge variation in cost and quality between and among the systems in Connecticut. So what does that mean? A knee replacement in one system may be 24%, 29% more expensive than in another system and have lower quality. What does that mean? Lower quality might mean that in those systems that there's more of a propensity for you to be paying for complications and infections and things of this nature. So the simple answer is that these big market movers have done the analysis on episodes of care, figured out what those things are that are most prone to be the big chunks of cost inside of their plans, and created, like Lisa was saying before, clinically integrated ways to steer from primary care physicians into these episodes of care, to create incentives for employees and dependents to utilize those types of plans. Massachusetts, for example, has an infrastructure for actually looking at health systems in their cost and quality and grading them on these types of things. But all of these systems that are being innovative have adopted an alternative payment methodology. You could call that the targeted price and warranted episode of care. And they are focused on predictable costs and quality and warranted outcomes and steering to those things. So those are in a very simple way, basically what all of these different systems are focused on doing.
Thanks, Jeff. I want to ask one more question to Lisa, if you don't mind. So, we're talking real high level here. In section 1 and section 2, we're going to be, talking more boots on the ground. And I wanted to just ask you about your experience in Massachusetts and here in Connecticut on that integration component, because, ultimately we need docs, at the patient level to kind of comply with this integration. I know many people on the call have been in the business for 20, 30, even 40 years. What does that integration look like for, primary care docs and those, really boots on the ground? And are they susceptible to moving to this disruption, and change that really, it makes sense at a high level, but how practical is it, on the ground level?
Yeah, Representative Woods, that's a really good question. In Massachusetts, I would say a lot of this integration didn't happen until the state took a more aggressive approach with requiring providers to assume more risk in value-based arrangements, alternative payment arrangements, and moving their Medicaid program to a Medicaid ACO structure. They did that under the 1115 waiver process to help fund primary care in particular, and help fund the investments needed for primary care to be able to assume risk. This doesn't happen with the normal practice. There are investments that are needed, and the state recognized that and seeded some money into a lot of primary care practices, required them to take Medicaid ACO risk, and they were able to leverage those dollars across all their populations. And to be able to do this integration and do this level of work in management, because it does require looking at patients in a different way and understanding what's happening to them through the course of their care.
Great, thank you. Definitely have some follow-up with you on that. Move to Representative Meskers.
Thank you very much, Madam Chair. First, I guess I want to make some brief observations and then, some questions. The problem I have with healthcare studies and the value-based model is that when I sit here as an ex-banker and look at the system and structurally, I've got pharmaceutical companies who have unfettered access to raising prices. I have medical device manufacturers who seem to have unfettered access to raising prices in the construction of medical devices, so that, the purchase of a hip, which I wouldn't describe as high tech, but a hip replacement, the purchase of a hip is probably what the price of a decent sedan costs. And I don't know how innovative every hip is, but since they're mass produced, I don't understand why a hip is $15,000 to $25,000 to the hospital versus $5,000 to the manufacturer. So there's a whole cost structure there, I think, is horrific. So one of the things I'd like guidance from you guys on is where in the price points in the system are there national impediments versus local impediments to organize the purchasing and to source the purchasing and the pricing so that we're not stuck paying 1,000 times the source price for products. I understand pharmaceuticals is the most difficult. I have to think medical devices are another area. The second piece where I look at the system that I'm confused or annoyed is I've got insurance companies, and Sue's listening, probably wondering where I'm going to go with this. But I've got insurance companies which I think do an adequate job of mitigating risk, spreading the cost across the system. But as the cost is compounding to 7-10% a year, I tell Sue, at some point, we'll be at 50,000 a year for insurance. It'll surpass everyone's Social Security annual payments to be insured. And the only benefit, of course, is that everyone on Social Security is on Medicaid. But the average person is going to spend, what, 20, 30, 40,000 a couple of years for their healthcare insurance. It's unsustainable. And there, if we can comment a little bit, I know there's one lawsuit pending. I think it's St. Francis with the insurance industry. I probably would personally look at a more conflicted relationship between my insurance carriers and my healthcare providers, because the hospitals are all nonprofits. The cost structure is pretty big. I'm concerned about that. And that will take me into the last piece, which is the medical provider system. I hear from the value-based system that we think that retail care, the general practitioners, are underpaid. Given where prices are in the United States, that means clearly people are overpaid. So I'm concerned when we move to a value-based model, we're going to be bringing, we're going to try to control the costs on one side and move the costs forward to, or the benefits forward to the general practitioners for point of service care to improve the quality of point of service care. Not opposed to that. I think that's a very brilliant strategy. My concern is we're ceding ground on where the baseline cost structure is, and we haven't figured out whether we're surrendering on that. And that, and the last piece of my commentary will go potentially into certificate of need. So we certify people on certificate of need, and I'm concerned with certificate of need that ends up becoming part of the cost basis for the insurance claims and insurance prices. So all of the risk is borne. It's kind of interesting. I looked at it like a utility model. I certify everyone to put up an MRI because of the benefits we've weighed, and there's not a look back period when they put in something I don't need or the promises aren't delivered and the cost is borne. Ultimately, it comes to the ratepayer. So the cost is borne by the insurance company who gives it to me as the insured. And I want to get, I know that's a lot, but I look at it, I'm worrying if we're cutting at the margin. And so when you give me guidance going forward, there are two, I think you guys need to put on two hats with us. Tammy Nuccio, myself, and our chair have all been to NCOIL. So we've got a state regulatory body we speak to, but we also speak to the NAICC to some level. So I'd love to know what you think we can fix at the state level. And instead of avoiding or not, tell us what pointed solutions you might have that we can advocate at the National Council of Insurance Legislators to go to the National Association of Insurance Commissioners to advocate for some of the cuts at the federal level, put them on notice that the local legislatures need the federal government to step up and the National Association of Insurance Commissioners to force some of the changes, not to the insurance industry, but to the negotiated stance on what's driving up our costs, whether it be on pharmaceutical prices, medical devices. We can't regulate them at the state level. We need to have people bring some more accountability to those price structures. And we haven't talked about that case. And that's my lecture, and I apologize. It's all over the place.
Why don't we let Lisa or Jeff or Sue respond to all of that? Jeff,
So-
go ahead.
Yeah, and I'm done as a relief. Don't worry. That was my entire source. Okay.
So real quick, I'm going to use something that Susan and Lisa both talked about. The market movers here on all the issues that you described are the purchasers who have self-funded medical plans, and that's about 64% of the employers in the state. And that's not just the state of Connecticut and the Hartford and Pitney Bowes and Stanley and ESPN. There are small group self-funded products going down to 10 lives in Connecticut that don't come under insurance commissioner regulation except for stop loss. The analogy that I want to draw here, and it's a really important one, you talked about the federal government, is the example that they're setting or directionality for policy. And if we look at what CMMI is doing relative to Medicare Advantage, and I don't want to go down a hole with this, but it's really important, I think. CMMI's new direct contracting model that they have gone out to providers and health systems with is not a shared savings model. It says to providers, you have all downside risk. You will have that patient assigned or attributed to you, as Lisa said before, and you will enter into agreements with health systems, specialists, other providers to manage the risk appropriately, whether it's a hip, durable medical equipment, it's medication, whatever the case might be, you have all of that risk and you are going to manage it. And that's a big deal. It's really hard. As Lisa said in her presentation, that includes relationships with point solutions and tech-enabled groups and virtual care providers and even direct pharmacy relationships and things of this nature. So just a comment about directionality and payment reform and care transformation. Back specifically to your question about hips and knees and things of this nature, what we're seeing, and it's really quite remarkable, and you need to look at this at home, is the huge variation in service lines between health systems in this state. What do they charge for a hip replacement? I mean, we've got health systems that charge 30% more and have worse quality. So this whole notion of adopting an APM, an alternative payment methodology, in a targeted price and warranted episode of care says that that baby will cost $14,500, not $55,000, which it does in places in Connecticut, a routine delivery, but it'll cost $14,500 because the folks who have agreed to provide that service have agreed to provide that service for that price and that level of quality as well. So why is that important to the state of Connecticut? Why is it important to every employer who buys stop loss? Because it gives them a predictable cost and quality outcome for those services. And everything that is involved in that episode of care is part of the way they say they can apportion it or deliver it into the system. That does not exist in Connecticut right now. We have blinders on relative to the huge variation in cost and quality between our systems. We don't talk about it. In other states that are succeeding, they talk about it, they measure it, they demand that level of accountability.
Yeah, and let me make one more comment here. I understand exactly what you're saying. You're worried about this, balloon effect. You push down on one area and the other area explodes. And I would say that what we're doing today isn't working. And value-based care is the light at the end of the tunnel, but it can't occur in isolation of some consideration and regulation for other parts of the industry that are adding to the problem. Right. So for many years, the federal government and others have pointed to providers as the problem for the lot that we're dealing with healthcare. And we are part of the problem, but we're not the entire problem. If you look at pharmaceutical spending now, it's upwards of 45% of the medical spend. If you look at devices like you're talking about, that's what's causing the economic squeeze at a provider level when we are in a value-based environment, because there's no regulation around those two components. And then we need to talk about reform in our insurance industry in some fashion. So we're not saying it's the entire solution to our problem. We're saying it's a solution to bend the curve of the costs that we're experiencing. It will not resolve the entire problem without consideration of these other items.
Thank you so much. Senator Anwar.
Thank you, Madam Chair. Thank you for setting up this informational hearing. I'll make some comments and then hopefully some of the speakers can reflect on my comments. Again, I think the hearing is about barriers for individual physicians and other providers. And I think this section should be titled in section A, how to increase those barriers. Because all I've heard right now is how do we increase those barriers and make it much more difficult for the patients to get the care. So if you look at the reality is at this time, whether it's Massachusetts or Connecticut, if Massachusetts is the beacon of hope, the individual patient who is required to pay is increasing. They're paying more at the ground. The amount that they're paying is increasing. And also the physicians in the community and maybe other providers, their satisfaction is being decreasing. And in Connecticut as well, right now, if we were to look and keep that as one of our priorities, I know they're beautiful buzzwords, and I've been listening to those buzzwords for the past 20 years, which is how do you have payment reform, integration, value-based, shared risk, and disrupting the system. It is disrupting the system. What is happening right now is if we were to say, okay, our priorities are one, that the patient is paying less, the cost is less, the state is paying less, and then the physicians who are providing the care are not leaving the state in droves or killing themselves. That would be a good quality criteria. And if you were to look at that, what has happened in all of these quote unquote disruptions is that money has gone from one pocket to other pockets, and the amount of money that is being spent has not decreased. And then that's a reality. It's going to the IT companies, the informational service, and also the consulting companies, and the middle person syndrome is alive and well in the healthcare industry, where there are more and more experts, quote unquote experts, who are getting more money. And end of the day, the cost to the state, cost to the patients is not decreasing, except that the providers, the barriers are increasing, and the two people in the picture. And then think about it for a second, and it's more obviously the people watching on CTN. There's no other industry in the planet where there's a transaction or interaction between two people, a patient and a physician. And the payment for that is so convoluted that it actually changes about a few hundred hands before the person who actually is providing the care gets paid. And as a result, both of them are suffering. So let's keep it simple instead of the buzzwords which killed us all. I'm sorry, it's an emotional issue because I see patients suffering every single day. Thank you.
Representative Nuccio. I'm sorry, Jeff Hogan, did you have a response?
Yeah, just a quick response is buzzword. There's plenty of buzzwords and vernacular in healthcare. There's no doubt. I get to work with hundreds of physicians and surgeons around the country, one of who will speak in a couple of minutes. And the reality for these states and purchasers that have moved into true predictable care paths that are clinically integrated with outcomes is that they're saving 30 or 40% and they're getting superior access. Those that have changed their practices, so they give 24/7 access for behavioral and PharmD and health coaches and things like that, have measurable improvement in their net promoter scores and patient reported outcomes. So I get it. I heard your speech, but the reality is we work for people who are looking for predictable outcomes and reducing their costs and improving consumer outcome. This marketplace right now, Americans don't trust healthcare at all. They don't trust government. They don't trust anybody. And the bottom line is they want and are demanding better. This directionality It reduces the variation in cost and quality. It's measurable, period. And the larger companies are doing it, and the larger states are doing it. Lisa just described Stu Leonard's. I'm sure you know Stu Leonard's. They decreased their total cost of care by 37% in a year. So that is measurable. And that's my response.
Thank
And
you.
If I could just add really, really quickly, I think we have to go back to, a point that Representative Mesker's made, right? This is sustainability. And I think sustainability of, access to quality, affordable care is what this conversation is really about. And not, the reason these things have come into place is because the current model is not sustainable. And so I think that's, the direction. And Senator, you and I have had a lot of robust conversations, and I always appreciate, your viewpoint. And, there is a cultural aspect to all of this, right? Where we all have to look at, I think, the system a little bit differently. But, as always, we appreciate your comments.
Can I just say one more little thing? I think in all your criteria and the risk criteria, just add the cost to the patient and also retention of the healthcare workers and the satisfaction of the people providing care. If you would put that as a criteria, it would be a very right thing to do, because that is not a criteria. And if you look at what's happening right now, the healthcare providers are leaving the states and the patients are still paying high. So just a thought.
It's an important point, a point well taken.
Yes, yes. Senator Anwar, thank you so much for bringing that up. Working with healthcare providers every day, we see it every day. The administrative burden, I would say, even without the value-based environment, is huge. And, the requirements to deliver medicine are onerous. There needs to be some work in this area. And I do agree with you, the burnout and the departures that this creates is unbearable and could be catastrophic to the healthcare system. So we do evaluate that as part of our work. It's not something that gets evaluated in every healthcare transaction, and I think that that's also part of the problem.
Thank you. Last questions from Tammy Nuccio. Representative Nuccio, you're up.
Thank you. So I have a couple of questions for each person here. And thank you all for coming today. I know it was kind of a nightmare getting all this together, but I appreciate you guys all coming. And I'm looking forward to the second half of this also, because I think something that we need to try to understand when we're talking about these things is how it's going to affect those doctors that are on the ground. And I had some conversations recently with a provider group here in Tolland, and kind of mentioned this movement. You should have seen their faces when I said what we were talking about. So it's an item of concern for me. So for Jeff specifically, what Senator Anwar just brought up is something that I think we definitely need to consider. I don't know if anybody has seen the Times article today, but there's an opinion piece out there, probably with a bunch of nurses in it, and that talking about everybody is very conveniently talking about COVID and the burnout for nurses and doctors and all of that. But all of these long-term nurses are saying this is all stuff that's been going on for a long time, and COVID has just exacerbated it. And they had some pretty pointed things to say about administration and how 50% of any hospital cost is staffing and the rest of it's not, and how we've intentionally kind of compressed the staffing ratios and such. And right when I saw that, I reached out to a handful of nurses that I know to say, hey, look at this, what do you think? And they all said, spot on. So it's interesting to kind of wrap in also the provider perspective of this, which I think is something that we have to do, right? But we also have to be outside the box in thinking. So Jeff, you specifically mentioned Massachusetts health policy, Maine, Rhode Island, New Jersey, Colorado, Washington State. What I would be interested in is your opinion on how similar these laws are across these states, and what have we seen from quantitative data-driven results. And I'm going to preface that pretty much all of my questions here are going to be, these are all great anecdotally, but show me the numbers, show me the data points, so we can make data-driven decisions and not emotionally driven ones.
It's a good question. And I'll tell you that Every state is different significantly. Well, I've lived in Connecticut for 29 years. I grew up in Massachusetts on Cape Cod. Massachusetts, the commercial market is 3 times the size of the Connecticut market. Lisa knows that as well. And there is a 3x differential in total cost of care in the health systems going across the state. And you can start in Eastern Massachusetts and look at what Partners Healthcare charges, and then go west, literally get out to Worcester and what Reliant Healthcare charges, the total cost of care differentials. These are provider groups and health systems. Why is there a 3x total cost of care differential? I mean, it's an important point. It's directly to your point. In New Jersey, specifically, very densely populated area, why does a $20,000 knee cost $110,000 at the predominant facilities? This huge variation in cost and quality. And why would the same facility charge X to Medicare and 500 times X in the commercial marketplace? This is how screwed up our system is. You know, there is a tremendous lack of accountability, and the access thing is really important. What Lisa described before is that we have tons of legacy provider groups around the country that have been operating on fee-for-service reimbursements, volume-dependent fee-for-service for years and years and years. COVID hits, everybody shuts down, the volume is gone. There's an existential threat to their existence. You talk about staffing levels, the way they get paid no longer works. It became very clear. We had a pandemic. So these are all considerations right now. In our own backyard, take a look at a really good provider group, Starling Physicians. They're utilizing a national company right now called Agilon to show their doctors how to move into risk arrangements and do care transformation. This stuff is happening behind the scenes. So you know, show me the data. The data is right there. Look at Connecticut RAND hospital transparency results by hospital and by service line to see this variation in cost and quality, and what needs to happen to get to a predictable cost for all these types of services. Other states, they're doing different things. I'll tell you, in New Jersey in particular, we work very closely with the unions to say, what are your pain points? What are the things that you're most concerned about? And what do they say? Access to behavioral health. Well, you know, like Lisa said, our existing systems don't deliver that. So we've had to bring in tech-enabled virtual care for behavioral access, which has worked, you know, to solve the problem. So these are complex problems. This is not a panacea. As the representative said previously, there's a lot of buzzwords out there, but there's just a ton of hard work that has to be done to remove that variation and to get the access and to get the consumer involved as well.
So you mentioned something there that I think deserves a little bit more. So I agree with you. Every state is different. Every state is unique, but healthcare as a model, you know, if you think about what we're paying for is pretty standard. So again, I like the data. I like looking at, like you said, why is it cost X amount more here than it does there? And that's something that I think is incumbent upon us to do. You had mentioned too also about COVID and the provider thing, and I've had this conversation with Vicki Veltri when we start talking about you know, looking at increasing spend to provide to primary care physicians. In theory, I think it's great if you can show me that we're going to have a reduction further down the line. And if we're looking at this as simply as a model to make sure primary care physicians get paid, then I'm not interested. If it's not going to be something that is going to reduce the overall cost of healthcare at this point, we're going to be looking to pump 20% more money into one area without seeing a reduction anywhere else, which is just more spend, which to me doesn't necessarily make sense. So thank you for bringing that up. Lisa, the question that I have for you, one very simple for the people who are on the call or will watch this recording. Can you give a very brief description of what is meant when you say downside risk?
Sure. What is meant, but when I say downside risk is that in most of the value-based arrangements, the provider organization, let's take CMS, agrees to manage the population within, let's say, so that everybody can understand, a budget, right? A budget of healthcare spending. And if we manage within that budget, there's a sharing between the payers or Medicare and the provider for doing a good job for improving and reducing the cost below the budget and improving the quality. If we do not save any money and we end up spending more than the budget, then there's a similar risk sharing arrangement where the provider pays CMS or the carrier, the payer, a proportion of what was overspent.
Okay, so that truly ensures a partnership between the payer, which, as we said here, the majority of we've got Medicare, Medicaid, and then 75% of the commercial market is ASO. So that would directly either go to the federal government, the state government, or directly to employers. So thank you for that, because I think, again, that's one of those words that kind of get kicked around, but people don't necessarily always understand what downside and upside risk means. So you're talking about Southern New England Health and the health network there. You mentioned two things that I wanted to kind of dig in a little bit on. The clinically integrated piece of this. What I'm hearing for concern for the provider offices and such is it's almost like the assumption of taking on a lot more than they typically do now. And how do they do that, right? So we talked about lots of different things that we would like a primary care provider to do. And I hate to use this analogy, but we think about what we ask teachers to do, what we have to ask the police to do. We have all these different things. We just keep throwing things on these professions. And then we throw our hands up in the air and say, why are we having them do all this? They can't do all this, right? And then it's like we're back into the slide of how do we make that accurate again? So my concern that I'm hearing from primary care physicians is when we start talking about looking at this, I like to refer to it almost as like the old Kaiser model. You come in, first floor is doctor, second floor is prescription, third floor is x-ray, fourth floor is this, like having it all in there. How are we going to train the primary care physicians? And where I'm really concerned is, unfortunately, outside of like your network, like the Southern New England network, I'm concerned about the individual providers who have seen like an increase in administrative already and have to hire people to help negotiate all the stuff that they have with all the different insurance companies. Now we're going to be, I do not want to do anything that is going to push out the independent provider. So how do we handle that by keeping them independent? Because they keep all of you big networks in check from a competitive perspective.
Well, Representative Nucio, just to be clear, we have a number of independent providers that are in our network for the very reasons that you're talking about, because our network in the organization, Southern New England Healthcare Organization, provides the resources and the contracting efforts and the care management and the pharmacists and all the other and the social workers to be able to do that work. I think we would be doing ourselves a disservice to think that this level of transformation can occur with existing staffing and existing structure. And we're trying to be a solution, but it is an imperfect solution because you can't do it without the right investments. Our primary care providers need within their practices to have advanced primary care and the things that Jeff was talking about. They need different people around them to reduce the burden. Mm-hmm. In today's economics, they can't afford it. Right. So to ask them to do it individually is a near impossible thing to do. What we're trying to do as Southern New England Healthcare Organization to be a solution to this is to be able to move our way into this in as much of a fashion we can, in an affordable fashion, partner with our local state and CMS and our payer partners to try to transform the way we're working. It's slow. It's very slow to do it this way. But it's necessary. And the independent practice is incredibly important to this, because I don't think that there is one solution necessarily for every patient that, it's not a cookie cutter approach. Healthcare is local. And in certain places, an employed model may be helpful. In other places, an independent model is very necessary. And I think we need both in our industry in order to be successful.
I agree. And I think the only thing that really kind of trips me up is when we start talking about adding all of these different resources where all of these are additives to the cost of care. So trying to find that balance and where we're going to see care reduction if we're pumping up an area so much. And then,
Can I just add I'm sorry to.
No, go right ahead.
I just want to add one comment to clarify this. The investments, if you look at other nations and where they invest their money for healthcare, they don't invest it in the medical spend. They invest it in the things that I'm talking about. They invest it in the social spend and the preventative spend to avoid the higher end spend that ends up in a hospital usually. And so if we do this right, we're putting resources at the point of care that the patient needs it. We're understanding their chronic conditions, their social issues, their inequities, and we're working with community-based organizations to improve their health, to avoid a really expensive spend of an acute admission. That's where you get the savings. It's the reduction of acute admissions, unnecessary ED visits, unnecessary skilled nursing facility investments, and so on and so on and so on. And that unfortunately requires an initial investment to begin to make that change.
I agree. And then the last thing I'm going to leave you with, you don't have to answer now, but I'm hoping you can send us information on, as you said, Massachusetts this didn't happen until the state required providers to assume more risk. I know about the 1115 waiver quite well, but so again, I'm going to ask for the data and what exactly it was that they put in place and what their corresponding results have been from that. And then I'm going to stop talking because I can talk about this all day and Carrie will yell at me.
Thank you. I do want to move to what we're here for, which are the boots on the ground perspectives from the doctors. We have one more question from Senator Wong.
Thank you. And I appreciate everybody's patience, and you can tell there's a lot of desire to find out more information. So I appreciate everybody being here. So right to the three panelists, and you can answer quickly. How can we educate the public on the true cost of healthcare? I don't think you're on the front lines, boots on the ground, but I get the sneaking suspicion that most of the general public have no true idea of healthcare costs. I'll give you an example. We talk about being able to give, at-home test kits and free PCR testing. How many people realize from the onset that PCR testing at the beginning of this pandemic was about $120? I don't think people truly understand the real cost of healthcare, and you and your health plans and your providers on the front line. How can we do a better job with you to educate people? Is it a public list in regards to cost procedures, medical equipment, pharmaceutical drugs, admissions at hospital stays? It's if you truly understood that, and if the public understood that, they would understand that it's prohibitive, the quality of care. And so I'll stop talking and get three of your perspectives on the true education of the public in the outrageous cost sometimes of our healthcare system.
It's a really important, it's a really good question. Having been in the state forever and worked in other states as well, cost and quality and giving perspective is really hard. And, we've tried to do this with the Moving to Value Alliance. And quite frankly, I mentioned before, working with Vicki, who's going to speak later, to get people to contribute to our all payers claims database, their own data, so that we can really show what those costs are and the variation in those costs and the variation in quality across the state. I'll tell you, it's a very inside group. Even in healthcare, people aren't aware of the variation in cost and quality. It's really hard. Here's another one for you. A state of Connecticut employee health plan costs about double what the average private sector employer health plan costs. Nobody talks about that. Nobody in the marketplace. And there's really good federal data. It's called the MEPS database that will show you what do people pay in each state, in the small group marketplace, in the middle marketplace, in the large group marketplace. On average, it's a phenomenal database. But guess what? You gotta have to work with it. The RAND Hospital Transparency Report, which I've said at least 5 times today, is really worth looking at, and it's open source. You can see, what things cost in specific health systems in the commercial marketplace versus Medicaid or Medicare. It's crazy, the differences. This is a really hard thing to get people interested in. And I will tell you, I have two kids. My son is a cop in a local city, Bristol, and my daughter is a teacher. And, I sat down with them to show them what their health plan costs, their municipalities. They were astounded, the relation of that cost as a ratio to what they're earning. This is the big deal. How do we get in our state? How do we attract and keep businesses when our total cost of care in the commercial marketplace in many ways is a third of what people make or 40% of what people make? It's such an important issue, and quite frankly, we could have another hearing to discuss that specifically, and I'll stop there.
Yeah, I think that this is a really important question. And I don't think that it should be just price. It should be price and quality transparency. When you look at every other industry, I can go on Amazon and pretty much purchase anything and understand what I'm getting and the exact price of what I'm purchasing. If I want to buy a car, I can shop around because I have complete price and quality transparency with being able to make that purchase. The healthcare industry is the only industry where that transparency doesn't exist because it is incredibly complicated. There's a difference between pricing, I just need a lab test versus pricing diabetes. And that's the complexity in making the pricing, with coming up with the pricing, because the variation in people that have diabetes is huge. One person could be 10,000, another person could be 100,000 because of the care that they're receiving. But I do think that we can do much better. And I think a potential solution for the state to consider is an investment in the HIE, in the Connecticut HIE Connie, to aggregate all this data and spend some time doing independent price verification and quality verification and put it out there so it's consumable by a consumer, and not look to the industry necessarily to do it, because I don't think you would get the results that you need to be able to make it completely transparent for healthcare consumers in the state of Connecticut.
And I'd just like to echo what the previous speaker said, but also just leave you with an anecdote, a personal anecdote that I think illustrates exactly what you're talking about, Senator. And I know deductibles are not popular. I have a deductible. I have three family members currently on my plan. I started to get some explanation of benefits, which all of you well know, that said, my insurer was pending the claim until further information. Like any of you, you kind of like, what's this about, right? So I look down and I investigate, and they all came under a doctor's, heading, not a facility heading. And it turns out they were the PCR tests that three of us had, went out to get at a certain facility. And the charge for those PCR tests, I heard somebody mention 100 and something, were $291 each. And absolutely, I count on my insurer to say, I'm not paying that claim until you demonstrate why it's not. Because you know what? Until I meet my deductible, I'm paying that $291 per individual, per test that has gone to that. So I appreciate, the concerns about high deductibles. I appreciate the broader scope of what we're talking about in terms of data, but personal experience, I will not go to that facility again. I certainly am going to look further into why that cost is what it was. And there is nothing like personal experience to give you that education. And I'll leave it at that.
Yeah, and I appreciate that. I have heard other ones. How many people read their bills, right? Well, we're very lucky to have Vicky Veltre here kind of working with us on this stuff. My second question to all of you is benchmarking. Obviously, the governor's through his executive order has initiated it. But I wanted to ask of you, is it helpful for you to differentiate benchmarking and as Jeff mentioned earlier, the 3-level tiering that's across Massachusetts? does benchmarking help? And are you on the front lines working with our hospitals and compiling this data? And that's another dynamic that I wanted to get into, is the working dynamic with our health plans and our hospitals. I know hospitals are very much lauded and such a critical part in the front line right now, but their business nature with our health plans is a subject of great interest to me. And for all of our physicians that are waiting for Section 2, thank you very, very much for your patience. But I'd love to hear from the three of you where benchmarking comes in and how it could be a helpful road. And the goal that we're having in this public hearing is reducing cost and getting a better benchmark so we don't have that striation that Mr. Hogan mentioned about.
If you could answer the question in a few sentences, we need to move on to Section 2. So if anyone wants to answer that, just be as brief as possible. Thank you.
Thank you, Madam Chair.
So real quick, benchmarking is important. It served Massachusetts well. It's key, though, that that you're benchmarking, appropriately. So, for example, we have a primary care goal, and Vicky's worked really hard on that. And I know Lisa's been on that committee as well. I think it's important to realize now that our traditional legacy provider groups are bringing in outside resources to help them to share risk. And we have to be taking that investment into consideration as well, not those that are just landed in Connecticut specifically. We must be taking that into consideration in order to have an appropriate measure and benchmark.
Having worked in Massachusetts, I think you have to start somewhere. And the benchmark is a place to start with understanding what's actually occurring with the cost of healthcare in your state. What's important to providing or establishing a benchmark is the analysis that goes behind it to understand where the spending increases are occurring. I'm pretty sure that those that put the benchmarking in place in Massachusetts would say that what they expected is not what actually was generated when they put the benchmark in place. But it's been incredibly helpful. It was helpful on the provider side to understand how we were contributing to the benchmarking process or the escalation of costs in the state.
And on behalf of the carriers in the state, we have been at the table. I see both Vicky and Kelly on the line. They are great about holding the payers accountable in this process, and we have willingly participated in what we consider a collaborative agreement. There's always going to be some push and pull. The devil is always in the details, but I think it's the first time that I can remember in my 30-year career where you've had, high-level folks from every stakeholder community around the table having these conversations. So I think it's a very important dialogue and should continue.
Thank you very much. Thank you, Madam Chair, for the indulgence. Thank you all.
All right, we're going to move on to Section 2, and I just want to let the docs that are on know that if you cannot stay on for questions, that's totally fine. We understand you are limited with your time. And I'll just go in order from the agenda, and if those docs aren't on, we can come back to them later. First one is Dr. Steve Schutzer he's a co-founder of Upswing Health. Dr. Schutzer, welcome.
You're muted, Steve.
Alex, can you unmute him?
How about now?
Good.
Can you hear me? Okay, thank you. Thank you so much, Representative Wood and all of the legislators. I appreciate the opportunity. My name is Steve Schutzer. I'm here to pitch private practice. I'm an orthopedic surgeon. My specialty is joint replacement surgery. And by way of background, I've been in private practice for 34 years before a very brief 8-month stint of hospital employment. On January 1st of this year, I re-entered private practice with Advanced Orthopedics New England. I'm founder of the Connecticut Joint Replacement Institute at St. Francis, where I served as its medical director for 14 years. I'm currently the physician executive for 4 hospitals at Trinity New England and serve as the chair of the orthopedic service line. As you heard earlier today, I'm also one of the founders of the Moving to Value Alliance, which is a grassroots multi-stakeholder collaboration of individuals like Jeff and Paul Grady and John Rodas and Christine Arnold, all of whom have an intent and a passion to advance the value agenda throughout our state and beyond. So 15 years ago, when we launched CJRI, a colleague of mine who had just finished his MBA at the Harvard Business School asked me to read 3 books written by his mentors: Who Killed Healthcare by Reggie Herzlinger, Redefining Healthcare by by Teisberg and Porter, and Innovator's Prescription by Clay Christensen. It was really propitious timing for me because what followed was really an epiphany that initiated my conversion into a zealot, an apostle, if you would, for the value-based healthcare movement, because I knew then, 15 years ago, that there's a better way to practice medicine where the patient and the family are at the top of the pyramid. And I think we've had some success in creating these entities in a brick and mortar environment. So as you heard this morning, I was really glad to finish my surgery and listen to some of this, but healthcare is remarkably complex with a myriad of interrelated components involved with this transformation. And you've heard an earful this morning from folks that I've learned from for many, many years. So I'm going to be very brief on it, make one note and one comment. First, healthcare is in dire need of a fundamental inversion. We like to call it a Copernican revolution, where primary care providers who really provide bona fide healthcare and not well-paid specialists like me who deliver sick care are at the center of the ecosystem. Remember, primary care is the only medical discipline where increased spending leads to demonstrably better outcomes, period. Second, for years, I've always revealed my bias. In presentation after presentation, my bias is this, that the entrepreneurial spirit of the independent private practice physician working at an arm's length relationship with willing hospital partners or folks like Lisa Trumbull can more rapidly and effectively create sustainable healthcare value than other types of alignments such as physician employment. But like many biases, I may be wrong, but I believe there's a growing body of observational data to suggest it isn't. Having recently experienced employment, my commitment to private practice is even more resolute. Why? I don't know if you've read the book, The Puzzle of Motivation, but it really does boil down to Daniel Pink's 3 intrinsic motivators of human behavior, as described in his book, The Puzzle of Motivation, his TED Talk. 1, autonomy, to have control over a time or team or techniques. Mastery, the desire to improve and get better at all things that matter. And purpose, the yearning to do the work in the service of something larger than oneself. All of these, in my opinion, are at risk when physicians are employed and absorbed into that larger corporate structure. And in particular, the creativity, innovation really tend to be stifled and suffer. I once heard a behavioral psychologist consultant say, physicians may be employed, but they'll never be employees. And I can tell you that's true. Years ago, Dr. Ezekiel Manuel from UPenn and Professor Bob Kaplan from Harvard, the giants in their own right, both predicted, and I heard them predict that private practice would soon come to an end. Both have now tempered that early position, informed by some of the remarkable and measurable successful ventures, such as here at CJRI, that have proven them likely wrong. So before I finish, I want to make it really clear. I'm not suggesting continuing private practice with that incumbent fee-for-service, crank-it-out volume mindset, but rather private practice that embraces the principles of the value movement, is willing to participate in accountable care, to accept and manage risk. Under these circumstances, my colleagues know that I'm quite bullish on the future of the private practice of medicine. Now we need your help in preserving the sanctity of private practice and protect the shrinking cadre of private practice physicians. So thanks again for the opportunity this morning. I'd be happy to expand on these concepts, but I'll turn it back to you, Representative Wood. Thank you again.
Thank you, Dr. Schutzer. We're going to go to Dr. Robert Russo, Chief Medical Officer of the Connecticut State Medical Society. Thanks for joining us.
Thank you, Representative Wood and other members of the committee. All I can say is, wow. I mean, I heard a lot this morning that just makes me think you're looking at the wrong end of the horse. I mean, the reality of it is the primary care system that we're talking about is changing so rapidly that by the time people act, it's going to be too late. Doctors are very comfortable normally with the hospitals they work with. They know the executive committee, they know the chairmen of the various departments and things like that. And there is in some of the work groups, and again, I think we're all paying tribute to Vicki Veltri and her work groups, but the reality of it is the doctors are very comfortable with the hospitals. So as the barriers, and if we're talking about strict barriers, we're talking about things like pre-authorizations, high deductible plans, all of which adds to an administrative burden to the primary care offices. Those offices are breaking down because the weight of this is so much. We spend so much time arguing with an insurance company or arguing with various other systems in administration that we look now for what some of the speakers earlier were talking about, people that can help, especially with the social work and the mental health aspects, some of the billing systems, all this sort of thing. 3 years ago, the legislature had a commission that looked at high deductible health plans. It came up with 9 points. It's now 3 years later, and none of those 9 points have been accepted. So our problem is when you look at these sort of things, where are the results going to come from? So there is a worry that the hospitals are gobbling up each other and the hospitals are gobbling up the doctors and the private groups. And the reality of it is what's pushing that is the insurance companies. As things are added to it, again, pre-auth, high deductible health plans, and I'm going to deviate for a second about a high deductible plan. What happened is there's a contract between a patient and an insurance company that has a very high deductible. But who's responsible for collecting those monies is the physician groups. So what happens is you have a $10,000 deductible. You come into the office. We have no idea if you've met the deductible or not. And then suddenly we're the bill collector. We're the credit bureau. Patients will call and ask for payment plans or they won't pay at all. And the barrier is once they owe money, they don't want to come back and look you in the eye and keep asking for more services knowing they haven't paid. What should happen is the insurance companies should pay the doctor and then deal with their own clients, which they made the contract with, about what that deductible is. Why are the doctors responsible for that? A physician sits with a patient and tells them, I think you need an MRI. You get the pre-auth and a couple of things. There are anecdotal stories all over the place where the wrong person at the insurance company gave you the pre-auth. They shouldn't have done it, so it's denied. It's denied after the procedure. So now who's responsible for the bill? The patient? The patient says, well, what are you going to do about it, doctor? That you told me it was pre-auth and now it's not. I have an employee that's Medicare. He found out he was dropped from a Medicare Advantage program yesterday in September. And he had eye procedures between the September drop date and today. That sort of stuff adds such a burden to a private practice that it makes us look for help. It makes the physician say, who's going to help me? I can tell you, we trust the hospital systems. We trust the big groups, the Pro Health, the Sterlings, the community group in New Haven and things like that. And what one of the earlier speakers were talking about, we trust those groups to say, take the billing, take the problem we have with these pre-auths and the arguments. And in some of the roadmaps that are out there, you see where it says the insurance company is going to watch the doctors. It's going to watch the credentialing. It's going to watch the quality care. They're going to watch to make sure everything. I can tell you, I was in practice for almost 50 years in Connecticut. Never did an insurance company tell me what percentage of pre-auths were denied or accepted, nor did I ever get a list of why they were rejected or anything else like that. We're not for that. We're desperately against that concept of letting the people that deny you care, and it is a barrier if the pre-auth is denied in a lot of cases, if the doctor believes it's so, and you have to appeal it to the people that denied it. There's no other system. So, and it's the same problem we have with the high deductible. All of a sudden, the finance, and you talked a lot about finance, it is a great barrier. But the other issue that has not yet bubbled to the surface, it was mentioned slightly, But private practice in Connecticut's got a tremendous amount of Medicare, Medicare Advantage, Medicaid. Some of these solutions are not going to affect that. There's always this, I want to say, cop out about, well, there's a commercial product and then there's a self-insured product. There's very little difference between the two. You got to remember the same companies. You might be self-insured, but you're using the Anthem or you're using the Aetna or the United Health background plan.
Thank you, Doctor. Can you please summarize?
Not a problem. I'll be back, as they say. I'll give up my time now. Thank you for listening.
Thank you, Dr. Russo. Next up, we have Dr. David Emmel, who is a solo provider.
Thank you, Chairman Wood and members of the Insurance and Real Estate Committee for giving us this opportunity to talk to you about some of the problems that are impacting us, boots on the ground, as you put it yourself. I would just like to comment on how much we appreciate hearing the preceding talk in terms of models moving forward. Everyone recognizes we're at a crisis point in healthcare, and we need some solutions. But I would also like to support the concept of the independent practice, the small practice, and just going back to something Jeff said about trust. You can't manufacture trust. It's something that has to be earned. It takes time to do it. And the relationship between a patient and his physician is one of the things that's critical to building trust and making any of these systems work. As we get more complicated, more intricate parts, I'm concerned that we may be creating systems where physicians become detached from the relationship with patients. They become a cog in a big process, and they move around a lot and never develop that same kind of rapport that's critical for good quality and low-cost care. The issue that I'm specifically would like to talk to you about today, however, really relates to a much more immediate concern that all of us are facing, which is the problem of burdensome prior authorizations. Bob Russo got into a little of this in his talk, but it's a continuing problem and one we're hearing from all of our members. In addition to being an ophthalmologist, by the way, I happen to be the chair of the legislative committee. Most of you probably knew that, for the Connecticut State Medical Society. So I get to hear about this. It's impacted me as an ophthalmologist. I started off in Wethersfield 33 years ago with a single employee. It happened to be my wife, and she was able to do everything in the front office and the back office in terms of managing my practice, scheduling patients, and all the billing. It was really possible to do it with a single person. Now, at the point where I reached the end of my ability to practice as a solo physician, I had to have 6 employees doing all that, and one of them was devoted pretty much to obtaining prior authorizations. Right now in ophthalmology, we have 3 insurance companies that require prior authorizations. Aetna for every single cataract operation I do, WellCare in Oxford for also for every cataract operation, in United Healthcare for their commercial product. So that means pretty much for every patient I see, my surgical coordinator has to get on the phone. Sometimes it has to be done by fax. Sometimes it's telephone. Sometimes there are other systems for doing it. It's different for every insurance company. It takes a lot of organization, and it takes a ton of time. Typically an hour on the phone for each prior authorization, sometimes an hour and a half. Some of our members have said 4 hours on the phone, literally. And even then, we don't always get accurate information. We're dealing with people who are not terribly well informed, that may be reading from a menu. We may be told no prior authorization needed, the surgery gets done, and then we find out, in fact, prior authorization was required and the insurance company's not paying for it. And there's no reliable system for really being certain that when we've done our due diligence, that we will receive the compensation that's appropriate. This is immensely corrosive to the patient-physician relationship. We wind up in conversations with patients that are not about enhancing their care, making them see better, living better lives, but rather trying to explain why a procedure that we had told them was appropriate and important to their care was denied, and why they're stuck with a bill. And it does impact us, especially when we're talking about high deductible plans, for the reasons that several of the speakers have talked about, whether it's a $295 charge for a COVID test, or the fee for a cataract operation, and certainly some of these other services that are even far more expensive. It makes it very, very difficult to maintain that trust with a patient and to continue a high quality patient-physician relationship that leads to good care and avoidance of, progressive damage from degenerative diseases. I could go on a lot longer, but I think I can stop here and open it up for questions.
Thank you, Dr. Emmel. Next up, we have Joseph Quanta, President of the Community Medical Group. Dr. Quanta, are you on with us?
Yes, I'm here, Representative. Thank you.
Thank you for coming.
Good morning, everyone. Madam Chair, thank you for the invitation. It's my pleasure to present in front of the committee today. I want to introduce myself briefly. I'm Dr. Joe Quanta. I am the president of the Community Medical Group, and we are an organization of over 1,200 independent healthcare clinicians, including over 400 adult and pediatric primary care providers. And I am proud to say I am a primary care provider, and I will point out I believe I am the first primary care provider to speak at this forum today. And I think that's an important voice to be heard, considering the topic is to really our independent primary care providers. And I want to echo what's been said by many of the previous speakers about the transition to value-based care. In our organization, despite being an independent group that does not have a hospital attachment or affiliation to support us, has participated in all the programs that the larger organizations have participated in, and has resulted in a successful Medicare Shared Savings Program, participation in the State Episode of Care Program, and 10 years of experience and $1 million of shared savings to our payer partners, and more importantly, to the payers of healthcare in our ACO programs. And I point that out to really stress that the ability to transition to value-based care is not dependent upon where the provider lives or where the provider is employed, but it really is dependent upon the commitment of the provider organization to make that transition. I do want to spend the rest of my time speaking about, I think, the most important topic here, which is the dire straits that our independent practitioners, and particularly our primary care providers, are in, given the strains that they are under. And I really want to focus on our primary care providers, because I would not be doing my job if I didn't tell you how desperate the situation is for many of our primary care providers. And the experiences of the last 2 years in the COVID pandemic have only amplified many, many years of issues that have been going on. I have a very brief period of time, so I'm just going to stress at a very high level and be glad to elaborate on any of those later, what our primary care providers are experiencing. And it's basically a few fundamental issues: dramatically increased costs for us to manage and to run our practices and our businesses, increased responsibilities put upon us by all aspects of both the healthcare system and, importantly, just the general business environment in the state of Connecticut that we have to live through as small business owners, a dramatic inability to recruit clinical staff, and as of late, our non-clinical staff as well, which has become increasingly challenging, an aging clinician population, particularly among our physician base across the state. And then I think the dramatic pressures, which I think are correct, but are challenging for us to reform the way that healthcare is delivered. And this is all happening in a context where primary care providers in particular have lived in a world where the resources that were given to our side of the healthcare delivery system were dramatically underfunded. And I would echo Dr. Schutz's points before, that primary care is one of the areas where increased spending does reduce spending overall for the healthcare system. So it is incredibly important that we begin to try to find a mechanism to try to increase funding to primary care. But, and there's an important but here, every mechanism to increase funding to primary care in its current model is attached to the primary care providers providing increased services. Now, those increased services are noble and important, but let's think that through here. We have an underfunded, overworked group that needs increased resources just to maintain the status quo, but we tell them to get increased funding, you have to do more. And so we're just increasing this repetitive cycle where the independent primary care providers will not be able to keep their heads above water. It is that tension that then creates the impetus to drive primary care providers to look for other larger affiliations. And those affiliations may be good things for those providers and their patients or not. But my feeling is, I think we all agree here, having options for providers, options for patients, to have independent providers is very important for the healthcare system and for our patients. And my time is running out. I just want to also comment that we often say, well, what can we do? What can the legislature do? And a lot of folks here today have said, well, there's nothing that can be done, or it's complicated because there's too many pieces of the healthcare system. But there is a lot that can be done. And I'll call out 5 pieces of legislation that both this committee and this legislature has chosen not to move forward with that actually would help primary care providers. The medical assistant vaccine legislation has been put up for vote many times and never been passed. The Association of Health Plans for medical groups has also been put forward to try to help lower health costs for providers. The permanent codification of the telehealth rules that are in place has not been done. I remind this committee that those rules are still temporary. The passing of the proposed rules for high deductible health plans, that's been discussed by my colleagues at length. And then rules and regulations regarding the interactions of payers and providers. And I think the prior auth rule is one example of that. There are many, many other rules that this committee and the legislature could enact, which would dramatically help healthcare providers, in addition to trying to help provide the increased funding and support that primary care providers need. So I'll pause there in my comments, and we'll be glad to have further discussion during the question and answer. Thank you.
Thank you, Dr. Quanta. Those were really great points that we will definitely circle back to. Is Dr. Khan still on? I know that he was on earlier. Yeah. Hello, Dr. Khan. Thank you for waiting so long. I know you have a busy day today.
Absolutely. Okay, I just, Representative Wood and the members of the committee, thank you for the opportunity to speak with you. I've been in practice for 42 years in Connecticut. I'm a past president of both Hartford County and the Connecticut Podiatry Associations. And Representative Wood thought I might have some interesting perspectives. And I thought that what I would do is I would spend a little time talking about the movement toward group practices, which does threaten some of the small independent docs and how they work. And over the last few years, we've seen a definitive consolidation of practices into larger groups. And some are being promoted by large healthcare organizations such as Hartford Healthcare and others. And what they seek to do is to maintain control and keep activity within their own networks. Others are consolidations of smaller group practices or larger consolidations with venture capitalists who are in it for one thing, as we all know. There are some advantages and disadvantages to docs that are independent practices from joining or not joining. And I thought I'd just hit those briefly for you. Advantages basically are related to management. So there's an awful lot of management that goes on in small practices, even some of which Dr. Emmel had mentioned in his previous discussion. But if you can unload the day-to-day demands such as staffing, regulatory issues, which can be very consuming, you can really just spend time being a doc. Other programs that we have to consider being in compliance with are HIPAA and OSHA and the variety of federal programs, and they are time consuming. The disadvantages of going into a larger group practice are basically, many of them have central booking, so you lose control. So it can make scheduling difficult for many of us. I mean, I'm sure that you've all had the opportunity to try to make an appointment and have experienced frustration trying to get through and establishing an actual appointment time. One of the more difficult problems is the loss of independence for the specialists and the docs that stay outside of the organizations. Some organizations require all their referrals to their own specialists, and this can be done only through one of their PCPs or one of their other docs. This blocks access for patients from doctors outside the group, and this can be, symptomatic and problematic for all of us, because I've experienced it myself. This could also lead to something called churning. I don't know if you're familiar with churning, but oftentimes within a larger group, there's a tendency to bounce a patient from one doc to another doc to another doc, and it generates sometimes, excessive amounts of care, which may not be truly medically necessary. So I think there's some things that you might be able to assist the independents and small practices with. The first would be really prohibiting group practices from blocking outside providers from referring into their groups. So I don't know. That's probably one of the biggest things I can see. I know I've spoken with Representative Wood about ways to attract docs to the state, and by providing some financial assistance and reducing debt. Wonderful idea if it can be brought about. And the last thing for me really revolves around podiatry, and that would be fee equity within the profession and within the insurance industry. And that's pretty much what I had intended to talk about. Any questions?
Thank you. Thank you so much. We're going to open it up to questions. And I just want to make a few comments, which is, thank you, Dr. Quanta, for listing some specific things, because, that was the question we were going to ask. But I do want to say that we will look into the recommendations from the high deductible task force this year. We'll be relooking at association health plans. And I think you are hearing this across the board on recruitment and training, but we have discussed some student loan payoff bills through a public-private partnership program to help with the recruitment here in Connecticut. I did talk to some second-year medical students from the Connecticut Medical Society, and it was shocking to hear where Connecticut ranks in terms of a place to do business. And we have a lot of improvement that we can do, because Connecticut wants to be a place where we have quality healthcare, and recruiting some of the best talent is obviously going to be key going forward. So thank you all for sharing your stories. We greatly appreciate it. I want to open it up to Senator Anwar for questions.
Thank you, Madam Chair. Thank you, each and every one of the doctors who have come and spoken, and thank you for sharing your perspective. It is of a great value to hopefully each and every one of us. Last year, I actually had proposed a bill, which was to say that insurance companies should not be in the practice of owning medical practices. And that was because 29 other states in the entire United States have said this is a conflict of interest. And there's no reason why an insurance company should be owning a medical practice, because the insurance industries look at medical loss ratios as their responsibility to try and restrict care, because that is how they make their profits. And owning the medical practice, and unfortunately in the state of Connecticut, the largest primary care practice, one of the largest, is owned by an insurance company. And to me, there's an inherent problem, and obviously I was not in representing my state and my community at that time. But this is a problem that we have, and I think if somebody can reflect on this, because there's a conflict of interest and we have a problem, and to have one of the largest group being that way is an issue. So that's something that you can reflect on, or share your thoughts with me if you could. The second part, and I think that's for Dr. Quaranta, I know you had a little bit more to say, so I'd love for you to complete what you were going to say, but also at the same time, when we say value-based, what happens is, and I'm going to try to give an example. If the insurance company says that, Dr. Quaranta, for your services, we are going to pay you $100, but guess what? We are going to pay you $85. And in order to get your actual $100 that you're supposed to get, it is going to be quote unquote value based. You have to have 95% of your patients have colonoscopies. And we know that there is not going to be 100% compliance with patients. If you get 93%, you lose your money. And if you get 95%, you get some of your money, or 96%. But they say next year, well, you will keep your 85 again. Now you have to go to 97%. So you're competing against yourself. So there's no win situation. And we know for the last segment of like 2 or 3%, your patients who are going to refuse, you are actually against the probability of not being able to do it. Think about it. At that time, many of the doctors actually say, well, we are going to actually have these patients leave our practice and then find somebody else because they're not compliant, and they're actually making your numbers look poor in this value-based, evidence-based information system that we have created. So the patients are actually being asked to leave in some of those situations. Can you imagine what would happen if we were doing the same thing with vaccines right now? So again, another thing to reflect on and maybe share the numbers and behind the scene drama that happens with our the sustainability of a practice. I'll stop here to Madam Chair for that, allowing me to ask the question.
Yeah, I'll just have any of the docs jump in and answer that. I know Dr. Quanta, some of those questions were addressed to you.
I'd like to, you raise an excellent point about the intersection between value-based care programs and payments. And it's one of the challenges that we've had, and our organization has been a participant in literally dozens of programs over 10 years. And one of the struggles is to find a program that appropriately balances incentives to providers, acknowledges the role of patients and patients' choice and patients' decision-making in that process, but also then really incentivizes providers for the things that they can control. And I think that's the key issue, Senator, is that many of our value-based programs begin to start to try to place responsibility on providers for some things that are difficult or challenging for them to control. And it's not that we're not focused or interested in those things, but it moves beyond the things that we can do. And when you tie value-based programs to our compensation to a high degree in that sense, then that becomes very challenging. I'll give a very specific concrete example. In the value-based world, there's, this has happened where a new introduction of a new treatment or a new drug comes out in a given year and dramatically drives up costs in that given year. Now that drug is a good thing, it brings value to patients, but all of a sudden the total cost, total spend that year increases. And then physicians who are in value-based programs would actually bear a penalty perhaps for that. And so it's an excellent point. Or if you have a patient population that prefers to have certain things done, even though as a provider you have actually recommended that, it can actually impact your compensation. So I think the key issue, going back to the primary care issue, is we have to establish and reset the floor, reestablish the baseline of what we actually can pay primary care providers to be able to be sustaining the role that they need to do. And then I think having value-based programs that are tied to things that the physicians and the providers can control, not the things that are out of their control at this point, are key to trying to tie into that compensation.
Thank you. And maybe I can just add another quick little question, Madam Chair. We have not talked about the malpractice insurance cost and the fact that any of the physicians who are in the business, their homes are not protected by a mistake that even the insurance company would refuse for an MRI to be done on a headache. Well, you're the one who's going to lose their home, and the insurance company will only be responsible for the cost of that MRI. And this is actually another reason a lot of doctors actually are making their homes in other states right now. Can anybody reflect on this issue too?
Yeah, I think it's important to point out that a lot of the referral patterns that we're talking about sometimes are also driven by the malpractice environment. I mean, we've seen, I've testified multiple times as an expert witness where you get a primary care physician on the stand and then say to them, why did you not refer this patient? When it's actually a patient in the disease process that's easily handled in primary care. It is not the qualifications of the primary care physician being limited. It's the, in quotes, cover the house or cover the home from being taken by not winding up with these accusations about that patient should have been referred. It's actually the insurance companies or even the malpractice atmosphere that is driving some of those referrals. So you desperately need reform.
Thank you so much. Thank you.
Okay, great. Let's go to Representative Comey.
Thank you, Chairwoman Wood. I want to look a little bit further down the road if we don't resolve some of these issues. It seems to me from the first part of the program to the second part of the program, we sort of we have these structural issues with healthcare that have made us have to create solutions to these problems that are now problems in and of themselves. But you know, I'm thinking about just another field just outside of the primary care field, in that just in mental health care, what's happening. providers continue to leave networks, and being in networks, and just are choosing to go to private pays, to a private pay model. And I think some of that is due to the fact that our demand is so high for that. Now, if some of the issues that we've heard today are, and I've spoken to some of my doctors that have gone under Hartford Healthcare and those sorts of things, are physician recruitment, and of course the administrative burdens of the different insurance requirements. I'm wondering if you see this as something that could happen to the primary care field and caregivers down the road, or what you see the future is if we don't resolve some of these really important structural issues, but the specific issues that Dr. Quaranta brought up. Thank you.
I think there's two answers. One, what you're talking about is one of the solutions that the physicians are going towards, which is a concierge type practice. I'm dropping out to get rid of the administrative burden, and I'll just deal, with fee for service without an insurance company in. The second, though, which is looking forward in Connecticut, it's actually Vicky Veltri's group that is putting together the work groups and bringing the different groups together to be able to look at two things: short-term and strategic long-term plans. I mean, one of the problems I know the legislature has is you don't have a 10-year term. The terms are short, so it takes a while to work through the system. I mean, we brought it up earlier. It's been 3 years since we had some solutions for the high deductible plan, but we are relying now, I think, much more on Vicky Veltri's group and others to bring us together like you're doing today. Your committee is putting us together to be able to talk about these things and iron out some of it. So there are solutions, but is the concierge the practice that we want? And what is that going to do to the Medicaid, Medicare population? And it's not a large enough solution, but it is one. And then these value-added systems have benefits. The question is, what benefits are we as physicians and patients willing to accept?
Anyone else want to jump in there?
If I may, so I think, Representative Comey, one of the fundamental issues we're dealing with in primary care recruitment development fall along two spheres. One is that in general, in healthcare, when clinicians are making choices about their career, primary care in general has become a less attractive choice to providers. And there are many factors in that, but they all go back to what I outlined previously: increased demands, increased burdens, lower compensation, and a perceived workload that is more onerous and burdensome to them over time. And so that's the national environment. And then in Connecticut, we have to then add on all the challenges that we face as a state. And some of those are parallel to other types of positions. Connecticut is a challenging area to recruit to. But again, in Connecticut as well, that there are challenges. And the fundamental problem is that there are very few primary care doctors, very few primary care clinicians. We're all competing to try to bring those into our respective groups. And so for independent providers, we don't have the resources, we don't have the funds to help support those. And I would have to defer to them in specific detail, but I'm certain a lot of the organizations that are hiring primary care providers that are part of larger entities are really using their larger financial wherewithal to help support those primary care positions, and they're not being funded directly through the primary care providers influx of revenue. So again, a lot of this goes back to the core revenue generation relative to costs that we have. It's a simple business problem, are not enough to support and recruit. And many of us go out and try to recruit providers, and we have young physicians who want to come. It makes a great match. But when you look at what the market sets for their salaries, the small independent groups cannot support that. If I may make one further comment, you mentioned behavioral health. I think it's an important point. And we did see what happened in behavioral health was providers left the insurance market. And we are seeing in primary care, particularly on the adult side, more and more providers start to leave the insurance market to go into concierge. And I do think that should be of concern to all of us, because if that movement starts to quicken, it could have significant ramifications in the market. And the final point on behavioral health is, you're exactly right. Many of our behavioral health providers exist outside of the insurance world in a self-pay model. And we have to rectify that situation. But I will point out, we have a very unique structure for how we build a network for behavioral health providers. And those networks are carved out of the rest of the medical networks, and they create two separate categories, and they're treated fundamentally differently in the market. So my group, we have behavioral health providers in our network. We cannot contract, we cannot represent our behavioral health providers because that network is considered separately. And ultimately, I think it's created a situation where, to be very blunt, the network adequacy for behavioral health in this state does not meet the standards that it should. And somewhere in the administrative or the legislative body or regulators, we need to look at whether it meets network adequacy and ask the payers, how can they come up with a network that meets adequacy?
Thank you. Representative Nuccio.
Thank you, Madam. Thank you. So you just said something, Dr. Quanta, that I've been saying, and since the minute that I got here, and actually got legislation passed for, and still can't get everybody on my task force to discuss exactly that, right? The network adequacy of mental health payers, and why we see them leaving, why they won't be in network, and how to bridge the gap between that. And you hit it directly on the head, having two different networks and having two different pay methodologies, schedules, ideas, value for service, et cetera, which we could go down a whole nother path. I would love to sit down and talk to you about that. But getting back to the individual provider here. So what I heard you say, and I'm marrying this up to what Dr. Schutzer said also, is for these independent providers, these primary care physicians is what I'm looking at here, is primary care physicians and this new model that we're anticipating. Having something like, if I'm right, and I might be wrong, please correct me if I'm wrong, but what Lisa Trumbull was saying with the Sony network, I see this being problematic for individual providers is if you want to stay an individual provider, and now you're expected to do all these different things as a PCP, right? So you have to have all these other care, coordination of care things happening in your office. You hiring 4 people to do that specifically as an individual provider is going to be extremely cost preventative, and it's going to increase the cost of care. And regardless of the value model, it's going to mean not necessarily more profit or less profit, but less profit for you. Whereas if we had something, I'm trying to kind of make a bridge here. If we had more like the Sony, which helps the individual provider with these items, and can manage these resources, and then it becomes part of that payment model. These massive groups have all these people. They have the billing departments. They have the people to deal with insurance. If we say you have to deal with the social determinants of health, they're going to have an easier time hiring those people and building their costs into their already existing model. Whereas an individual provider, I think, is really going to struggle with that. So at least that's what I'm hearing. Please tell me if I'm wrong, but I think that's what I'm getting from Dr. Schutzer and you, is that, you know, we need to invest in the primary care model, but we can't put our hands on your head and hold you under the water while we're doing it, and not accounting for the fact that it's going to be significantly more expensive for you to do this than it is going to be for a Hartford Healthcare or a St. Francis or a major provider model. So either of you two, if you want to comment on
it. I think, Representative, there are different paths for different provider groups depending upon where they live in the healthcare ecosystem. And I think that for truly independent providers, they can do much of what, and they already do much of what is already being asked of them. And you know, we talk about my office. We had care coordinators. We've had them for 20 years before anybody called them care coordinators, right? But they were really long-term staff in our office who worked and helped us manage and take care of our patients. And so I think there are many pathways to try to transition to more complex models. I think the point is, no matter where the provider lives in the healthcare ecosystem, the direct funding that goes into the primary care bucket is small. When you're attached to a larger organization that has more resources, they're better able to shift funding from other parts of the pie into the primary care bucket. So that's one way, that's one mechanism that larger entities can help support primary care. What I would propose is that's not really the only way we should or want to actually support primary care. And we should be able to support independent primary care directly over time. And again, one of the big differences between those large organizations and the independent organizations is they have better ability to have better contract terms with the insurance companies. And so that has to be said here, that part of what's funding and supporting those increased resources is their ability to negotiate better terms with the insurance companies, which goes back to the point we're talking about. If the independent providers were better funded, they could be doing these things. They could have built up the infrastructure. And I don't want to say that, I don't want to say that increased funding to primary care shouldn't be tied to increased performance. I just caution those to understand that to ask that to be done upfront before they have access to increased funding will be challenging for those primary care providers to do. We have to level set, get them to the point where their practice is so secure as we help them transition to using increased funding to provide increased services. And I think in that case, it doesn't matter where the provider lives. They could be working for a large entity if that's what they feel is best for them, or they could be independent and accomplish the same goals.
Thank you.
Dr. Schutzer, do you have a follow-up?
You're on mute, sir.
Just a very quick comment. So, I was going to be a family practice doctor. I went to UVA, and I just saw myself taking care of patients. And then my love for tinkering took over, and I became an orthopedic surgeon, which I love. But I have a lot of friends that are primary care docs, and I just can't imagine 10 hours of dealing with chronic medical conditions with 15 minutes a visit to deal with diabetes, hypertension, obesity, behavioral health problems. And by the way, my shoulder hurts next, right? I mean, I just can't imagine 10 hours of that work and 2 hours of paperwork before they go home. It's just not tenable. And it should be such a great profession, Joe. I mean, I love fixing people's hips and knees and getting them on their feet. But what a great thing to see people lose weight, healthier lifestyle. That's what you should be paid for, right? For taking care of these problems, not by every 15-minute blocks. So I just want to put a word. I'm a big supporter of Joe's. I love his model, love CMG, and whatever we can do to help our primary care colleagues, I'm 100% behind it. Thank you.
Thank you. Any other questions? Thank you so much to all the doctors that joined us. We have a lot of follow-up that we'll be reaching out to you on, and I really appreciate you spending this time today. Just to bring this all full circle, I want to go to section 3, which is to Vicki Veltri. We are moving towards more primary care investment in the state of Connecticut, and based on everything we just heard today, I'm really looking forward to having this discussion with you, Vicki. Thank you for joining us with your team. I see a lot of your team on as well.
Thank you so much, Representative Wood and the members of the committee. I'm really happy to see a larger group with us because we've been talking to a smaller group for quite some time, but I think having a larger group here is a good thing. With me today, I have Michael Baylett, who's been supporting the work of OHS around primary care investment and the cost growth benchmark, quality benchmarks, et cetera. Kelly Cinco is our Director of Healthcare Innovation. She's also on. We have a short deck. I will try to skip some of the slides based on what you've heard from our physician partners here related to some of the barriers that they have raised, which is one of the reasons we've gone down the road with them. So Michael, I think, is controlling the deck. And I'll just start off by saying we have heard directly from primary care providers, associations, and practice groups that we have met with repeatedly about the challenges in primary care, which really begin on page 2, but you've heard them, right? The same things that have been brought up today: aging workforce, burnout, fewer medical students entering primary care, difficulty retaining people when they've gone to medical school here in Connecticut. You can move to the next slide, Michael. And people have reported to us as well, administrative requirements raise significant barriers to them be able to practice the way they need to practice. The limitations of fee-for-service payment, only reimbursing discrete kinds of procedures and services and being a barrier to treating the patient for other needs that the patient presents with. And access to and use of health information technology. That also came up. These are particularly problematic, as you heard today, for the smaller independent practices. So we can move to the next slide, Michael. We have been working deliberately since last April to do two things. Look at how much we're actually spending on primary care in the state of Connecticut. And then how can we better promote advanced primary care in the state of Connecticut? So through the benchmark work that had begun under the governor's executive order number 5, we've already put together a baseline year of spending. We've collected a lot of data from our health carriers about not just the health plans that are insurance plans in the state of Connecticut, but also the self-funded market in Connecticut. So the data you're seeing here reflects all the data we've collected thus far. Right now, Connecticut is spending, or at least as of 2019, and we don't really have a reason to believe it's gone above this amount since that time, about 5% of overall healthcare spending is going to primary care, 5%. That means the remaining 95 is going to everything else. That's well below, or that's below what Medicaid is currently spending, which is about 8%. And it's below other states who have also set primary care spending targets like we have in the state of Connecticut. Rhode Island has set a target of 10.7. Delaware has set a target of 11.5. Those are consistent with our target of 10% by 2025 on primary care. We do believe primary care is the foundation of the delivery system, which is why the governor has made it such a priority to do, I think, what Dr. Schutzer referenced, which is essentially turning things on its head and resourcing primary care better. So next slide, please, Michael. Again, 2 parts of the executive order. One is the primary care spending target. We hope to achieve a much higher spending on primary care by 2025. The original target was set for 10%. We're at 5 now, like I said, and improved primary care. So helping our independence, helping our practices strengthen and sustain primary care. It's absolutely critical in Connecticut to do that. Next slide. So again, all payers equal 10% by 2025 is the target that's in the current in executive order number 5. We've established interim targets to try to get to that 10% by 2025. I will say again, the targets are not an end in and of itself. They're a path, they're a means to an end. It's to try to facilitate this kind of work on strengthening and advancing primary care that we've been invested for over a year now. Next slide, please, Michael. Steve said this, I think somebody else said this, Steve Schutzer. Research has demonstrated that this investment in primary care correlates with better outcomes, lower costs, and improved patient experience. There is a robust set of evidence demonstrating that advanced primary care that we have specified in the roadmap will lead to reduced spending overall in healthcare and improved quality. Next slide, please. So we have a roadmap that we have put out for public comments in a draft form right now. We had a public comment period that has since lapsed. However, obviously we're, would welcome input from our legislative partners. That roadmap includes 4 items here on this slide. Core function expectation, heard from Dr. Quanta, like what are we asking our primary care providers to do? Core function expectations are in this roadmap that for primary care practice teams, not just individual providers, but their practice teams. And importantly, the resources and the supports to help these teams achieve these functions. This is really critical for the independent practices that don't get, as you heard, the supports that the larger systems can provide those primary care providers. It also, the roadmap includes ways, as Dr. Quaranta said before, getting investment is good, but maybe you may want to assess performance, but you need to do it by resourcing practices. So here we resource the practice, but we also have methods to recognize how the team is performing. And importantly, we offer voluntary, because there's a lot of misinformation out there, I think, about this roadmap, voluntary primary care alternative payment models beyond traditional fee-for-service models to reimburse primary care. So it means voluntary advanced primary care model and potentially a fee-for-service plus type model where people could also stay in fee-for-service but achieve these core functions and still get the supports that we're trying to offer. Next slide, Michael. Again, the roadmap that we've put out is really focused on the commercial market. However, we have consulted with DSS, the Medicaid program, so it's aligned with where directionally DSS is going. That's very critical because we know from our provider partners that when you have expectations from 6 different payers, it's really hard to do things consistently. And that includes quality measures and expectations of performance, et cetera. It was developed with input from patient advocates. We have had many engagements or multiple meetings with our practice representatives, including participants in the work group that we set up, but also other meetings that we've had offline and payers, the payer partners. It is feasible, it is achievable for our state to achieve this roadmap. Go ahead, Michael. And here's what we're hearing. So this is what we are hearing from the primary care practices. Notwithstanding, and we will be straight up and say, we have heard these challenges about health information technology. So we've gotten our Connie, as I think Lisa Trumbull mentioned early in her presentation. Connie is at the table, which is our state health information exchange, our health information technology officer, meeting with the practice organizations about how to help them through some of these technology challenges, whether it's instances of Epic being able to talk to each other, or whether it's they don't even have an EHR. How do we support these practices? So they are looped in. We've also talked to them about seriously about the shortage issues in primary care and what we are doing at OHS, which is to try to advance conversations with the governor's office, Office of Workforce Strategy on aligning primary care workforce issues with this roadmap. So that they're not standing independent from each other, but they go hand in glove. These are what the providers are telling us. You can read them for yourselves that this is important directionally to them. That one of the biggest challenges in practice is not having the kind of resources and supports they need and not being able to help pay attention to what people went to medical school for or what they went to nursing school for, but having to deal with other issues that might be better handled, let's say, by a nutritionist, by a behavioral health provider who's on the practice team, by a pharmacist doing medication reconciliation. So these are the things we've heard from our providers. Next slide, please, Michael. We obviously, continues to be an issue that people raise about increasing primary care resourcing. At the same time, is this just going to be an investment with no payoff on the other side? Well, as I said earlier, there's documented research about advanced primary care and reducing overall costs, but we do have a healthcare cost growth benchmark. And if payers, provider organizations adhere to that benchmark, then growth in primary care spending should not lead to increased rate of growth of medical spending. The idea of the benchmark is to lower the overall rate of growth in healthcare spending. There is going to have to be give and take on this, and that's the nature of the beast with this kind of work. The costs that we would add are a very modest cost to resource the practices, primary care practices, to help them achieve the mastery of these core functions that we have in the roadmap. Next slide, please. So this is sort of an illustration about rebalancing spending. Here's where we are now, right? The left-hand side is where we are now. Spending continues to increase. As a result, overall spending has increased. Primary care spending as a share of that spending goes down, while spending has continued to increase. On the right hand of the graph, you can see that we're not expecting healthcare spending absolutely to stop growing, but we expect to slow the rate of that overall spending while we increase the resourcing of primary care. So the overall rate of spending growth comes down. It's right now, I can tell you based on the data we will air out with our steering committee on Monday, the commercial rate of growth of spending exceeds our current benchmark. If that rate of growth consistently comes down, then the share of primary care spending with our resources will increase as a share of the total medical expenses that we are putting out every year in Connecticut. Next slide, please, Michael. Other states have done this. Connecticut is not new. We are behind. Actually, many states are ahead of us. Colorado, Delaware, Oregon, Rhode Island. Others have implemented these primary care targets for the same reason we are. which is the recognition that primary care is the bedrock of good healthcare. Other states have also implemented programs to support the transformation. That's Minnesota, Oregon, Rhode Island, Vermont are all doing it. Change like this is possible in our land of steady habits. And I know Jeff Hogan calls us sometimes the land of frozen molasses. Connecticut can do this, but it is going to take everybody at the table to do it. I think Sue Halpin mentioned that earlier. Everybody's got to be at the table. We've got to get out of our steady habits headset, or our mantra, and move forward. So how can we do this? How can we work with you to do this? So by supporting the cost growth benchmark, I think we've had lots and lots of discussions with people about the importance of the benchmark and the transparency that comes underneath it. And I think it's important to go back to what Senator Huang said. You cannot improve something that you don't measure, right? Up until the benchmark, initiative came and through the executive order. We haven't had a lot of transparency about healthcare spending in Connecticut. It's if you knew where to find it, maybe you could find it. But we are putting out data. The benchmark steering committee has been putting out data. OHS has been putting out data. Maybe we need to pump it out even more so the average person can see it. And we will be doing that through an updated cost estimator tool. But that information has to get out there. Supporting the primary care spend target is absolutely critical. I think unless we have our eyes on the horizon of where we want to get to, it's going to be hard for us to make the changes that we need to make. And supporting practices, particularly these smaller independent practices, who we think will probably get more resources through a roadmap like this if they choose to participate in a voluntary alternative payment program. They will likely get a higher share because they need those resources maybe more than a larger organization. So that's the direction we're going. I know you asked a lot of questions earlier, and I'm sorry that I missed most of the first panel, but we're happy to be here to answer any questions you might have about directionally where we're hoping to go, again, in partnership with all sectors in the healthcare space. That is our goal. But I think what I try to say at every one of these meetings, I think it's true. We all have to own that we have these issues around lack of resourcing for primary care, the healthcare cost growth that we're seeing in the state. We have to own them to be able to work on them, but we have to commit to working on them. We can't just be status quo. I don't think there's anybody on this call that thinks status quo is acceptable. So we need to move forward, but we need to do it in a way that makes sense and together. And we think the roadmap does that.
Thank
So
you, Vicki.
I'll stop there because I know you guys are running way behind.
Yeah.
I apologize.
No, we're going to open up to questions. I know that I have a few. I just want to make a comment that I think one of the things that we're going to have to work together on is the recruitment piece in this area. I mean, we have heard it from the docs in section 2, and we have this goal here in the state, but the reality is we have a lot of work to do in that space. So let's just make that a goal for us to continue to work towards. I know that I definitely would like to make that a priority. Also, can you just talk about the increase in spending on primary care? We heard a lot about we're going to increase spending in order to produce better outcomes. Like, what does that mean? What does improved primary care mean? I don't really know exactly what that increased spending means to improve outcomes. And I was wondering if you can kind of dive into the detail a little bit on that.
Sure. So I'll start and I'll let Michael fill in if he wants to. First, on your question about the recruitment. Absolutely necessary that we do something about the primary care recruitment. And that isn't just physician, MDs, it's also APRNs. And because this roadmap, addresses all the primary care kinds of practices. But what we have also heard from people, the practice associations, is not doing a roadmap like this will necessarily lessen our ability to attract people to the primary care workforce, because what's been happening is what Dr. Cuento alluded to earlier, more and more burden and less time to do it. And lots of people going into medical school today, people want lives. People want to be able to practice, but they want to have a life-work balance. They want to be able to address the needs of their patients that go necessarily beyond medical care, but they can't do it with the way the healthcare system is structured right now. So there is a piece of the workforce challenge that is addressed, I think, by the roadmap itself. But that's not to say there isn't a ton more work to be done on workforce recruitment. Regarding the outcomes, there's a couple ways to look at that. One is healthcare outcomes as we traditionally define them. So in the roadmap, or if we get to implementation phase, we would be looking for, as in many, many alternative payment models, quality measures, whether it's patient experience, whether are people's diabetes under control? Is their high blood pressure under control? And we would look to hopefully stratify those kinds of outcomes by race, ethnicity, and language as we're moving forward to collect that kind of information. And then there's physician outcomes, quality of life, right? Has quality of life improved by physicians? And there's patient outcomes. What was my experience like? Is my experience improved with so there's a range of outcomes that could be included. Specifically, I think we've gone towards the traditional ones, but would pair those with others as recommended by our consumers with whom we are going to engage in some deep focus groups moving forward, and our provider partners. But Michael, do you want to add anything to that?
Yeah, a couple things. Here's what I think added investment in primary care produces. First, it helps practices build teams. Joe talked about using care coordinators and how organizations that can negotiate better contracts are better paid. Well, so what do you do with the extra pay? You're able to build teams to deliver care. And what do practice teams do? Well, so for adults, they help the practices both prevent and manage chronic illness, and chronic illness is the source of most healthcare spending. And for kids, they do different things. For kids, they help address social risk factors or social determinants of health and coordinate services for kids that prevent higher spending when the kids are adults. So that's what the added investment provides. The added investment also, though, encourages physicians to go into primary care and to stay in primary care. And that's a really basic need, because if we don't have enough primary care clinicians, we can't deliver primary care. So I would say that's what you get for the investment.
Excellent, thank you. I'll open up to questions. Senator Anwar.
Thank you, Madam Chair. Thank you, Vicki, again for your work. And then again, I had the opportunity to read the roadmap in detail, and I'm sure you have received my feedback already, written one that I had sent, right?
Yes, we have it. In fact, we were trying to set up a time to walk through it more with you. Yeah.
Good. And I think we have touched on some of those talks. One of the areas was, of course, making sure that trained individuals who have spent 3-4 years of training to be the ones on top of your teams, rather than anybody who says that they're doing primary care and not have had the training to be the primary care, if you will. So that's, I think, an important part, because we have to, in the entire document, there's no conversation on excellence in care. So I think excellence has to be very important. I know we want to be able to save money, but we also at the same time have to make sure that our citizens in the state of Connecticut will get excellent health care. And then for excellence, the best thing that we can do is we have some of the best training teaching programs for physicians in the country. And then we should be able to identify ways of recruiting those individuals. The question, Vicki, I wanted to ask you was that this is music to my ears when you say that we are going to increase the spending on primary care, because the ROI in healthcare is so much higher when we invest in primary care. Wanted to know what is going to happen to the Medicaid dollars. I know, is the Medicaid dollars going to follow the pattern of increase in the investment for the Medicaid dollars? Are they going to be the ones that are going to be increased in the coming years? And if the Medicaid dollars are going to be increased in the investments in primary care, is the total Medicaid budget going to increase? And if not, that means somebody's got to give. And who is that somebody who's going to give? Is it going to be less orthopedic surgeries, less eye surgeries? What is going to be the reduction in the Medicaid investment when you're going to actually shift it towards primary care?
So let me answer the first one first. So first of all, thank you for writing a comment. And I just want to assure you that the goal of the roadmap is to not lessen the role of the primary care physician or an APR and whomever's, the lead of that practice. It's designed to help the physician or an APRN or something be doing the things they want to do and that they're trained to do, and have the supports around them to handle the things that are creating burdens for them right now. So whether it's a medication reconciliation issue or a behavioral health issue or something like that, to have those resources available. So that's essentially that kind of focus. Regarding Medicaid, I can't answer exactly what Medicaid's roadmap for itself would be for the future. I know they are aligned with us in their thought process around how to move forward in resourcing primary care practices more. So I think there's more to come on the Medicaid side because that's under the umbrella of DSS. But I do want to say when it comes to the spending side of the equation, I just want to be clear that the intent here is not to say people who need eye exams and people who need a knee replacement or people who need a transplant, for God's sake, something very extreme like that, would not get them. It's to cut off, right? To let the primary care practice team deal with the things that primary care practitioners can do, practicing to the scope of their license with the supports around them, right? Intervene early to prevent some of these things from needing to happen so people are healthier, so they may not need, right, those other services. For people who are chronically ill may continue to need those services. The intent is not to cut off absolute spending for people. It's to simply resource primary care better and improve outcome, their clinical outcomes and life experience. I don't know, Michael, do you want to contribute anything? I mean, I can't, to be honest, I don't know that we can really speak for Medicaid since they're not on the call. But that is a good question to ask DSS, who I think is aligned with us moving forward.
So I think, and Vicky, we have had these conversations. One of the challenge I sometimes feel is your office is serving as a think tank as well for the state to be able to say, okay, we have done our groundwork. We have these working groups. This is the vision after talking to all the experts of taking care of the health issues for our state. But these become just documents and intellectual knowledge when it does not translate in policy. And there's a disconnect with the legislators. And I think somebody else alluded to this, is that because as legislators, we keep changing or moving or doing different things. So we do not really translate that into a policy as much as we could or we should. And so we have to figure out a way to bridge that gap as well in some ways, because a lot of effort goes into what you're doing. And obviously you are also doing it with a very minuscule resources, if you will, because I know that at times you guys are struggling and sweating with little resources that you have, and we are trying to still take away whatever you have left now. And so with that in mind, we need a long-term strategy for OHS to be able to unleash its full potential. I don't know if this is a good way to have that conversation.
Can't disagree with you on that. Every one of these things. So one of the reasons that the office sort of came about was the need for development of these kinds of policies, cross-sector, multi-payer initiatives, multi-provider. And you've heard others address it, like we do convene a lot of work groups and we try to ensure that we're including the voices of each component of, the healthcare ether, including patients in all of our work. Not all of it lends itself well to legislation. Some of it does. So like the benchmark, for instance, right? That's something that's translatable to legislation. When it comes to alternative payment models, maybe not. And it depends on, obviously part of the market is self-funded, right? We have a significant portion of the market that's self-funded. But it could be, right? If you got people to the table and have that kind of bearing out. Some of them take a little longer time than, unfortunately, like the 2 months of session. Like this year, we have a short session, right? But we're committed to that kind of thinking, obviously centered on where we want these things to be long-term strategies and embedded in our culture, right? That we're all moving together towards containing healthcare costs in a way that makes sense, that improves the quality of care, that resources our practitioners. But this is not an easy lift. by any stretch of the imagination. And it has taken probably what we're at it. This is 2 years now since the executive order got signed. And it's been a lot of work to like bring people together and break down those silos and walls between the different stakeholders in the healthcare space. But, you know, I can't say you're wrong about your point. Things have to translate to policy. And one of the reasons the benchmark steering committee was set up is to do that, is to say, look, you guys know now what we're seeing in our data, right? From the all payer claims database in terms of where dollars are being spent. And from our benchmark data collection, where are the dollars being spent? What does the quality of care look like? What are we going to agree on to tackle together to take on these issues? We have the senior executives of the insurance companies, the hospital systems, employers, a union rep, etc., all at the same table to say, look, we need, you're the ones that are decision makers in your sectors, right? Help us move the needle, because we don't want to come then to you all fighting amongst each other, right? Because that's kind of what happens usually, right? Is that people then go back into their boxes and start advocating and pointing fingers. This entire effort is about collaboration, which is the non-traditional way of doing things sometimes, to be quite honest. But I can't say I disagree with you at all on your point, though. But
And finally, Madam Chair, if you would allow me, I think because this is a roadmap that your office has come up with, which hopefully will improve a little bit after some of the comments that and public comments that you have probably received, and I know there's quite a few that have been there. Would all of those comments be made public too? And then second part is that if this is going to be a roadmap that we as individual legislators are collectively say it's a good idea, do you think it's worthy to make sure that the other part of the agencies, like for example, the Medicaid concept could be clarified? Because if the Medicaid dollars are not going to increase, then this is a very good intellectual exercise.
Answer first to the first part, easy. Yes, all comments will be public. And we are currently digesting them and figuring out how to place them into the roadmap, et cetera. And I, yes, I think I agree on the second part, right? Like we have been working with DSS behind the scenes. They are, I think, advancing a primary care strategy for the Medicaid program. I'm not sure about all the details yet, but I think that's typically comes out in the MAPOC. The MAPOC is the Council on Medical Assistance Program Oversight, which is really the oversight body that people participate in on the Medicaid program. So that's usually where they air that. But you should know that we try to work hand in glove with them, as well as the Comptroller's Office, by the way, who controls the state healthcare spend on these initiatives. So behind the scenes, there's been a lot of that partnering and discussion. But, we can do more to make it more transparent. Move forward.
And if there's no other question, can I just ask another one? In one of the meetings, thank you, Madam Chair. In one of the meetings, Vicky, I sensed in the conversation with the University of Connecticut, it was obviously not said in a very clear manner the way I'm going to say it. It was almost felt that we could use University of Connecticut even more with all the intellectual resources to be able to create more programs to test what you're working on.
So that, I haven't heard that in a meeting, but maybe it was a meeting I wasn't at. So I have to apologize if it was said in a meeting I wasn't at. But I mean, I'm always happy to work with UConn. We have a lot of partnerships with UConn. So if there's something that could be tested, I mean, I would hope the UConn medical group, given its size, would want to do something like this roadmap. So that's welcome. That would be welcome news. And obviously, I'm happy to talk to Andrea or I know Dr. Agwanobi's leaving, but anybody over at UConn. I think we have a good relationship with them. So
perfect. Thank you so much.
Any other questions from the committee? All right, thank you.
Thank
Vicki,
you.
the whole team at OHS. We always appreciate everything you're doing. I want to thank everyone that came today. It gave us a lot of food for thought, and we will be doing a follow-up internally and then hopefully addressing some of the stuff in the upcoming session. So look forward to working with everyone and have a wonderful day.
Thank you very much.
So much.